professionals who are pioneers in their fields with years of experience and who are eager to impart their wisdom. So we hope you enjoy the conference. Without much delay, let's welcome our first speaker, Dr. Archana Bilage is a consultant neonatologist at St. Philomena's Hospital, Bengaluru.
Shall I start?
Yes, ma'am, you can start.
I'll start showing the slides.
Madam can see us.
Ma'am, can you see us?
Yes, I can.
Okay, ma'am. Please start, ma'am.
Can you see the slides?
Yes, ma'am.
Can you see my slides?
Yes, ma'am. Yes, ma'am. We can see your slides.
Okay, so shall I start now?
Yes, ma'am, please.
Okay, thank you so much. Thank you for the organizers for having invited me to this prestigious National Reform Conference and asking me to speak on one of the topics that's very dear to my heart, that is assessment during neonatal resuscitation. Now, as you know, asphyxia is one of the leading causes of neonatal mortality in India and in other countries. It's very important to give a good start in the postnatal life. Not just in the postnatal life, as soon after birth that is, but also in the NIC. So resuscitation becomes very important. However, resuscitation is a teamwork, it's a team effort. For example, when I'm resuscitating a baby and the other assistants are not trained or are not qualified or don't have the knowledge to help me, it becomes a very tedious task. It leads to a lot of confusion, a lot of delays, a lot of yellings. So, on the other hand, if I have my nurses who are trained helping me with the resuscitation, oh, it is so beautiful. It becomes like a smooth machine work. It leads to good outcomes. So I'm here to talk about how you as a nurse can assist during neonatal resuscitation. Like I said, resuscitation is teamwork, where we have a team leader and there are other team members. The team leader is the one who organizes a group, monitors a performance, and is able to perform all the skills. He or she also directs other team members and provides critique of group performance after the resuscitation effort. The team members have to understand their role. They should be willing, able, and skilled to perform the role. They should understand the NRP steps, and they should be committed to the success of the team. Now, ideally, this is what a resuscitation area should look like. There is a baby in the center. There is a person who is in charge of the airway. There is a person who is in charge of the circulation. There is a person who is monitoring the breathing. There is a person who is preparing medications. There is a recorder who is recording all the events with the timings. And there is a person who is a leader watching and directing everybody. However, in real world, this does not happen. We do not have so many personnel helping us. We may have at the most 3 people. One is a main person and 2 other nurses or 1 more physician. But what, in my experience, what I have seen is that nurses play a passive role. They wait for instructions. They don't take the steps. They don't talk out. There's also lack of communication, especially closed-loop communication. Like, for example, when the nurse is told to do something, whether that nurse has been or not is not communicated. So then, how to be a good team member? One is you should have the knowledge and you should practice in the form of drills. You should be aware of what's happening during resuscitation. You should be able to evaluate and anticipate the need, the next step, and be ready for it. You should be bold to speak up and interact. Don't keep mum. Speak up. see what's going on and ask. The knowledge and practice. One, you must undergo NRP training and you must participate in mock drills. At the time of resuscitation, readiness is very important. All-round readiness. The equipment, warm-up, you should know what are the risk factors so that you can anticipate and plan the steps. There should be enough personnel and you should know the umbilical cord management, whether there's going to be delayed cord clamping or not. This is just a picture of all the equipment that is required, which you know very well, so I will not go in detail. It's easy if you have a pre-resuscitation checklist, which you can check during every shift or every day to see that all the equipment is ready at the resuscitation or in the NICU. This is available in all textbooks and on internet. I will not go in detail with this. But what is important is these things should be checked whether they are available and they are in working condition. Like the ambu bag. You should know how to check the ambu bag, whether it can reflate once you press, whether it can recoil, whether the pop of valve is working, whether the pressure is being delivered through the mask. Then you should know what mask size is necessary, whether it's a term or a preterm baby, and keep the mask size ready. For more than 34 weeks, it should be a term mask, and for less than 34 weeks, it is a preterm mask. Suction should be connected and kept ready at pressures of 80 to 100. Oxygen should be connected, and you should be ready to turn it on to 10 meters flow. ET2, depending on the size of the baby, should be adjusted, should be kept ready. Now, NRP is simple. They're just main steps. They're just these 4 main steps. First is drying, suctioning, and stimulation. Second is ventilate the lungs. That is positive pressure ventilation. Third is make sure the heart rate is okay. So if required, give chest compressions. And finally, circulation. You may require to give adrenaline and NS pills. It's as simple as that. Now, NRP is beautiful in a way that no matter what size the baby is, what gestation the baby is, the steps are the same. And these steps apply even in the NICU. So here we go. The first step is drying, suctioning, and stimulation. What are you going to do when the performer, when the main person or the doctor is performing these steps? You can see the person, the doctor usually, who is a doctor, or the nurse who is performing, drying the baby, suctioning the baby, and stimulating the baby. What are you going to do as an assistant? You get ready for positive pressure ventilation. Check if the baby is breathing or crying. If the baby is breathing or crying, you don't need to do anything much. You don't have to get the bag and mask out. Otherwise, you get ready with the bag. Important to remember that babies who are less than 32 weeks, there is no drying involved. They should receive the baby in a plastic sheet. Now, how do you get ready for positive pressure ventilation? Now, I already discussed before birth, you should decide the size of the mask. Then, when you're handing the bag and mask to the performer, remember that for more than 35 weeks. So don't connect oxygen tubing, do not connect reservoir either. Just give the ambu bag for bag and mask. If it is a preterm baby who is less than 32 weeks, then FiO2 recommended is 0.21 to 0.3. Now this you can accomplish only if you have an oxygen air blender. Now many units in India or many labor rooms in India do not have a blender. Now what can you do in cases of that? It's very dangerous to give 100% oxygen to a baby, a preterm baby, which increases the risk of ROP. So what I often tell my team is that you give me the bag, connect the oxygen, but don't connect the reservoir. It gives up to 40% oxygen. That is any day better than 100% oxygen. But of course, you should be ready to move to 100% oxygen as and when required. Now this is a T-piece resuscitator. I hope you have seen this. Now this can be used instead of an ambu bag. It gives pressures, uniform pressures during the resuscitation, and it can also give PEEP, which is important for a preterm baby. Now what are you doing when the performer starts positive pressure ventilation? Check the heart rate. Check to see if there is chest rise. Attach the pulse oximeter to the right hand. It's important to attach to the right hand because that is a recommendation. So, 2 things you do when the ambu bag starts. 1, check the heart rate. Second, attach pulse oximeter. And here I would like to add, if you're the only two people here, call for help, get one more assistant because you will need another person if the heart rate is low. If the heart rate is low and once the positive pressure ventilation starts, recheck the heart rate after 15 seconds. That is about 10 breaths. Now if the performer will want to know if the heart rate is rising, announce it, announce the heart rate. Don't just check the heart rate and keep quiet. Announce it. Is it rising? If it is less than 60, more than 60. And then the performer will know what to do. And then meanwhile, also get ready for intubation. Among all this, I should mention that once the baby is born, the timer needs to be started and we should be keeping on checking how much time has elapsed during resuscitation. Because all the steps of resuscitation are timed. Now, how do you check the heart rate in a baby? There are 4 ways to check. One is attach a pulse oximeter and that gives the heart rate. But the pulse oximeter will actually start reading after about 1.5 minutes. So you cannot rely on that. Second is pulsation, palpation of the umbilical cord. You can feel the pulses. That comes only with experience. If you're not experienced, you will not be able to palpate well. You may misread, you may be counting more or less. The best way is auscultation. So take the stethoscope and listen to the heart rate directly over the chest. ECG is the one that is recommended now, and that again has to come through in all the units. That is the fastest way and the most accurate way to get an ECG, to get the pulse rate. Now, how do you check a heart rate? You count for 6 seconds and multiply by 10. Or easier way said is add a 0 at the end. If you get a heart rate of 4, the heart rate becomes, add a 0, it becomes 40. If you count 12 beats in 6 seconds, the heart rate is 120, and so on and so forth. Now make sure that during positive pressure ventilation, the head is slightly extended. You may be, as an assistant, you may be able to check all this, that the performer is doing it correctly, that the head size is correct, that the mask size is correct, mask position is correct. It should cover the mouth and the nose and not the eyes, and nor should it go under the chin. And that you should check the performer is holding the position of the mask correctly. You may be the more experienced person sometimes. It may be a junior doctor who is doing bag and mask. So you can, as an assistant, check all this, that the mask position is correct, the side holding is correct, and the head position is correct. And then you make sure that the positive pressure ventilation technique is correct. We go for breathe 2, 3, breathe 2, 3, squeeze 2, 3, squeeze 2, 3. So this is the technique that the positive pressure ventilation is carried on. So make sure that this technique is being followed. And while you're observing all this, you attach the pulse oximeter to the right hand or the fist, but don't expect it to work right away. If the positive pressure ventilation is not working, that is, if there is no chest rise or if the heart rate is not increasing, the main resuscitator will ask for help. These are called as corrective steps. We remember them as MR SOPA. So the performer will readjust the head, the mask replacement, and then might ask for suction. So be ready for suctioning the mouth or the nose. Then the performer will open the mouth while providing breaths, and then will finally increase the pressures. So during these corrective steps, the assistant should be ready with a suction. That's the main role. And be ready to suction the mouth and the nose. Don't go too deep in while suctioning the mouth or the nose. The positive pressure ventilation is given for 30 seconds. What happens after 30 seconds? You can check the heart rate and see if the baby is breathing spontaneously. If the heart rate is good and if the baby is breathing spontaneously, check the saturation and consider oxygen if the saturation is low. If on the other hand the baby is not breathing but the heart rate is more than 60, what the performer has to do, the performer will continue positive pressure ventilation. You can check the saturation and see if oxygen is required. If oxygen saturation is less than 85%, you will be asked to attach oxygen. Suppose there is no breathing and the heart rate is less than 60. What happens then? the performer will ask to add oxygen. So you make it 100% oxygen by attaching the tubing and the reservoir, and then positive pressure ventilation is continued for another 30 seconds. After this, if the baby is still not breathing and the heart rate is less than 60, chest compressions will start. So you as an assistant will be asked to give chest compressions. Meanwhile, hopefully you have gotten ready for intubation. If there's another person there, that person can be ready for intubation and get adrenaline ready. So here is a baby who is breathing and crying well. So in that case, the baby goes to the mother for skin-to-skin care and direct breastfeeding. Whereas if the baby is not breathing and the heart rate is more than 100 or more than 60 actually, we check, continue positive pressure ventilation, check the saturation. There is an algorithm where it tells you how much oxygen saturation is expected at what time of life. So suppose the baby is now 3 minutes of life, the saturation of 70 to 75% is okay. You don't have to add oxygen then. But at the end of 5 minutes, if the oxygen saturation is less than 80%, you have to attach oxygen, or you have to give oxygen to the baby, or add oxygen to the ambu bag. And keep checking the heart rate every 30 seconds. Make sure the heart rate is not going low again. In case the positive pressure ventilation goes on for more than 3 minutes, you have to give an NG tube for gastric decompression. So put in an NG tube for this. Otherwise, the stomach will inflate and will hamper the positive pressure ventilation, will hamper the diaphragmatic movements. So in case the baby is not breathing and heart rate is good and you have continued positive pressure ventilation and the baby does recover soon, so it goes back to the mother for skin-to-skin care and breastfeeding. But if the positive pressure ventilation goes on for more than 3 minutes and then recovers, the baby needs to be observed, preferably in an ICU. But if the baby is not breathing and positive pressure ventilation is going on with a good heart rate, the next step will be intubation, transfer to an ICU. Before that, put in an NG tube. Then I just told you all this, that if the heart rate is low, add oxygen, make it 100% by attaching the tubing and the reservoir, get ready for intubation and start chest compressions. Meanwhile, keep adrenaline ready as well. So what are the indications for intubation? One is there is no response to positive pressure ventilation and the heart rate remains less than 100. Or if there is no spontaneous breathing, even after 3 to 5 minutes, but the heart rate is good, still it's better to intubate. And the other indication is if the chest compressions are going to start, it's preferred that the baby is intubated so the airway is secured. Now how do you assist for intubation? You keep ready the correct size of ET tube. There are guidelines. Here in the chart you can see according to birth weight and according to gestational age. The sizes of the ET tube vary from 2.5 to 3.5. But as you are aware that at birth you don't know the weight of the baby. So we go by gestational age. If the gestational age is less than 28, the preferred ET tube size is 2.5. And you tape it at 7 centimeters. If the baby is between 28 and 24 weeks, the preferred size is 3 and the depth of insertion is now 8 centimeters. If it's a term baby or more than 34 weeks, the preferred ET tube size is 3.5 and the depth of insertion is 9. So you have to remember this, put it up on the wall as a quick check. Because in that confusion you may not give the correct size ET tube. Keep ready suction, stethoscope, plaster and tegaderm. They should be ready of course prior to delivery. Once the baby is intubated, auscultate to make sure the breath sounds are equal. Auscultate in both the infraaxillary and the epigastric areas and announce that the breath sounds are good or equal or not heard. If the breath sounds are louder over the stomach, that means the baby is not intubated. Even if you think you can hear breath sounds in the chest. Then when you're taping, make sure the depth of the ET tube is correct. And recheck, re-auscultate to make sure that the breath sounds are equal. After intubation, positive pressure ventilation, as you know, continues with 100% oxygen. And after 30 seconds, chest compressions are started. The chest compressions The fingers, two thumb technique is preferred, and they are kept over the lower part of the sternum below the nipple line. And you encircle the chest like this. You can either stand at the side of the baby or at the head of the baby. And then you give chest compressions with positive pressure ventilation in the ratio of 3:1 for full 60 seconds. Keep an eye on the clock. So the technique is 1 and 2 and 3 and back. So when you say 1, 2 and 3, that's when you press in. And then you release when you say and. And when you say back, the person who is giving positive pressure ventilation will squeeze the back. Ideally or usually is a person who is doing the chest compressions that will do the counting. Again, it is said as 1 and 2 and 3 and back, 1 and 2 and 3 and back. If you use this technique, you end up giving about 90 chest compressions and 30 breaths in 1 minute. So during chest compressions, what all do you keep an eye on? One is make sure there is 100% oxygen connected to the ambu bag. Make sure the compressions are sharp and that the depth of the compression is deep. That is 1/3 of the chest should go in. And you will see if once, because the pulse oximeter is connected, you will see a waveform with each compression. That means these are good chest compressions. At this time, if you have ECG leads, please connect them. If you have not yet connected them. If you have not yet called for additional help, please call. And then very important is keep track of time. It's very easy how time just slips by. When the additional helper comes, adrenaline should be kept ready. That helper, many times before delivery itself, adrenaline is kept ready. In India, the concentration available is 1:1000. So you have to make it 1:10,000 by taking 1 ml and adding 9 ml normal saline in a 10 ml syringe. And please label it as adrenaline. At least write A or adre, something, or it might be mistaken as MS and somebody might just push it. Then keep ready equipment for umbilical vein access. Again, of course, this should be all ready before the delivery. You bring it closer to the warmer. Consider peripheral IV line also in case there is no person available to put an umbilical line. Now, when you are asked to give the adrenaline, the dose is 0.2 ml per kg. Now, again, the weight is not really known when the baby is born, so it becomes a little confusing. So, ideally, the performer, the male resuscitator, will tell directly the dose. Like it's a term baby, the performer might tell you give 0.5 ml. Preterm baby might be 0.2 ml, 0.3 ml. So, listen to the dose and give it in the umbilical vein that is inserted. Give it as a rapid push and follow it with a 3 ml MS. So that has to be kept ready and given. If you are giving a ET tube dose, suppose umbilical vein access is not ready yet, so you may be asked to give the dose through the ET tube. So dose there is 1 ml per kg. Here no flush is required. You just put it down rapidly to the ET tube. Now anticipate that the adrenaline doses will be repeated every 3 to 5 minutes if the heart rate is low. So keep the next dose and flush ready. Ask if MS bolus is required. If the MS bolus is required, 10 ml per kg is given over 5 to 10 minutes.
So I need to introduce myself again now. I'm Dr. Bhaskar, consultant and neurologist at Kaveri Hospital, Electronic City. So already Archana madam has explained you regarding the initial steps of resuscitation. Now the topic that I am going to tell is about techniques and points to remember during CPR medications using during resuscitation. Okay, so I'm going to take photos. There is not much in the slides. It's hardly 5 slides. So let's have an interactive session and let it be more practical use. Okay, so what are the medications that we use in CPR in neonates? Have Gupta? Adrenaline or epinephrine. Then for next slide. Next. Okay. Larry. Next slide go buddy. New slide go buddy. Okay. One is adrenaline, epinephrine, and next one is which commonly used. Next. Have the NS. Favorite NS. NS is the word that we commonly use in normal science and nursing superintendent also. Yeah. So NS, adrenaline, NS, and O negative PRBC. Yeah, theoretically yes, but practically it's very difficult to arrange in so fast while doing CPR. Okay. Next slide. So whatever the medication, you should know this almost 5 components. So when to administer? When to administer adrenaline? What kab dena? So whenever the doctor say. How? That's an easy method, right? How you should give adrenaline? This is an important thing. So if you know, it's very good. Because some sisters are really much experienced than the new doctors. Okay, so that's why you should know when to administer. So if heart rate is less than 60, even after effective positive pressure ventilation, you have done as madam told you before, effective positive pressure ventilation, followed by chest compression for 60 seconds with 100% FiO2. One is heart rate must be less than 60, effective positive pressure ventilation with effective chest compression for more than 60 seconds, not more than 60 seconds with 100% FiO2. Even then heart rate is not picking up more than 60, then you need to give adrenaline. So now I need to start adrenaline. So before madam has showed you in the previous slides that what are the things you should keep it ready. Adrenaline was one, and she also explained how to prepare it, right? So next question is how to prepare. So whenever you go to NICU, when OBG or an obstetrician calls you and says, okay, there is an iris case, so which child has child has a bradycardia in NST, so late exaggerations are there in NST, abnormal NST, and I think child may require some neonatal resuscitation. At that point of time, we should always keep it adrenaline ready, because adrenaline vial, I think it's doesn't cost more than 50 rupees. Okay, so don't think that waste ho jayega. So always keep it ready. So how you keep it ready? So adrenaline usually we get in 1:1000 dilution, and 1 ml equals always 1 mg. Okay, so take 1 ml of adrenaline, mix it in 9 ml of NS, normal saline. So what else you can do is you should take an adrenaline vial and put 1 ml syringe and 10 ml syringe.
Recording in progress.
And put a rubber band and keep it ready. Okay, so that whenever you should dilute, then you come to know, okay, I need to dilute it. Okay, so 1 ml of adrenaline, 9 ml of normal saline, mix it so it will become 10 ml. So it was 1:1000. After making it 10 times diluted, it will become 1:10,000. Okay, that's the preparation of adrenaline. This is how you prepare and label it. Madam has put it in a green word there, and she was highlighted that part, because that's a very important thing. Because if you don't label, some may, because in a hurry, some may tell us give you 10 ml of NS, then someone will give this adrenaline and you can give 10 ml of adrenaline to the child. That will be very harmful for the child. Okay. So how to prepare, I told. Now, what's the dose? So don't get, next slide. Regarding the dose, it's lot of confusions will be there. So I want you to remember a simple thing. So 1:10,000 dilution. So dose, intravenous is there, intratracheal is there. So the two doses are there. So intravenous, don't confuse between 0.1 to 0.3 ml per kg is the intravenous dose, and ET is 0.5 to 1 ml per kg. If you don't want to be, you should know only one thing is keep it as intravenous as 0.1 ml per kg and ET as 1 ml per kg. So it will be simple for you to remember. So if an intravenous dose, 0.1 ml kg per ml kg of 1:10,000 dilution. That's important. Okay, and ET is 1 ml per kg. So we don't know the birth weight of the child. As soon as the child, we can't wait because we will be doing CPR for the child, right? So how do you assess the birth weight? By clinical experience. If a doctor is an experience, he may say, okay, child may belong to 2.5 to 3 kg or 3.5 kg. Or if they have a scan, recently done scan, which shows the weight of the child, you can consider that also.
Recording in progress.
Okay, so this is it. So remember intravenous doses, 0.1 ml per kg. Heat is 1 ml. Don't get confused. 0.1 and 1. Simple. So that you remember that. 0.1, and I'm not telling in mg per kg because I don't want people to get confused. 1:10,000. 0.1 ml per kg is intravenous. 1 ml per kg is the heat. Okay. Previous slide. Okay. In this slide. Back side. So next is the route, as I said, do intravenous or intraosseous at the same dose, and next is ET. So intravenous, so IV cannula we should put, right, but in a CPR child, the veins will be collapsed. If you are able to get an IV cannula, well and good, or you are very much experienced. Otherwise, if you have a UVC set, as Madam has showed you before, we have assessed for UVC. Okay, so UVC, usually what we do, take a longer time and clinically clean the area, cut the clamp, so you need to be much faster over here. So one difference here, you need to keep an knot type so that it won't bleed much, and cut it properly. As you see the vein, take a 5 French depending upon the term of the child, put into UVC till you get blood. 3 to 4 centimeters, if you go inside, you will get blood. As soon as you get, you should stop it. In order to put it inside, take an X-ray, check it, then give adrenaline. Okay. So as soon as you get the blood, stop it. So that's where you hold it and give adrenaline. Intraosseous, okay, if you're not getting UVC or in a rural setup, UVC is very difficult, and you have an intraosseous needle. Intraosseous, if you don't have an UVC, I don't think you will have intraosseous needle. So what else you can do is, you can have 18 gauge needle. All OT will have, okay, the purple color and the pink color one, if I'm not wrong. Okay, so they can make 18 gauge needle. Where you have to put intraosseous is in the tibia, in the proximal part of the tibial, where to locate the tibial tuberosity, 1.5 to 2 centimeter below there, in the anteromedial part, this part. Are you able to see this part? Push it. We take an 18 number gauge needle, go with a screwing movement. As soon as it gets a give away. As soon as it give away, that means okay, you are in the bone marrow. Flush it. If there is no local swelling, nothing, okay, that means okay, you are in the bone marrow, you can give whatever drag possible. Okay, that is an intraosseous route. Umbilical okay, intraosseous okay. Then coming to the last one is how to administer. So if you are giving IV, adrenaline should always be given bolus most of the time. Okay, in a CPR, definitely bolus. So you give as early as possible, as fast as possible, and after giving adrenaline, it's better always to flush with 0.5 to 1 ml of NS, because it should not lie in the tubing itself. Okay, in ET, no flushing. If you flush, what happens? It will all go to lung. Okay? And ET dose is always higher side because the absorption we don't know how is going to absorb. So once you give adrenaline, ET if you are given or if you are given IV, what do you expect to do? What do you expect in Agbeco? It should have increase in heart rate. That's the reason, right, we are giving because after chest compression, heart rate is not improved. That's the reason we are giving an adrenaline. Adrenaline will have an inotropic and a chronotropic action. So as soon as you give, you need to, after giving adrenaline, we should continue CPR, chest compression and positive preventive ventilation for 60 seconds and check the heart rate again. If it's still low, you can repeat dose every 3 to 5 minutes when you're giving IV or intraosseous. ET usually one dose because we don't know the absorption, how much is going to absorb to the blood. Okay, and that's why we are giving a higher dose also. That's why 1 ml per kg. Okay, this is about the adrenaline. Okay, next is normal saline, NS. So NS usually the usual dose is NS we not give in every child. We will correct the CPR. When you think the child is in shock, how do you come to know the child is in shock? One is not responding to the adrenaline. You are given adrenaline 2 doses, also it's not responding. The child is very pale. The pulses are very weak. Okay, and there is a history of abruptio placenta, placenta previa, fetal blood loss, or severe bleeding in the mother, uterine rupture. If anything that is in the case and child is very pale, so at that point of time you can consider giving normal saline. How you give normal saline? Usually 10 ml per kg. Okay, the weight, as I said you before, you can analyze the weight by just looking or checking the ultrasound, antenatal ultrasound of the recently done. Okay, so 10 ml kg NS should not be given as a sudden bolus. In a term child, okay, on preterm child, it should not be. Why? What happens if I flush around 10 ml, 20 ml into the, so intraventricular hemorrhage are the one of main adverse effect if you give sudden NS. Okay, should be given over 5 to 10 minutes. Okay, so if given one dose of 5 to 10 minutes over 5 to 10 minutes you are given NS, still not responding, till child's pulses are weak. Okay, little improving heart rate but still pulses are weak. So you think, okay, it's responding to NS. Okay, you give one more dose. So we can repeat around 3 doses of normal saline. So O negative PRBC, as I mentioned early, can be given, but practically in Indian setup, it's very difficult to, because it all occurs within almost 4 minutes and so getting a blood bank, cooling it down and giving bolus, it will be little on the impractical side. Okay, if possible, if you already know the child is going to be bad, then if you already prepared for it, definitely you can go with O negative PRBC. Okay, these are the one which can be done during immediately after birth. So if a child in the ward, okay, and suddenly they called announce the clot blue and child is completely limp, no breathing, at that time you started a CPR. There you may think of dextrose also, not in the NRP. Okay, not in newborn. I am telling about in the water, because CPR can happen in anywhere. Okay, if that time you can consider of one more drug which I have not mentioned here is dextrose. So that is 1 to 2 ml per kg of D10%. Okay, if you check the sugar and always keep it ready in that condition. There other things will come up. Adrenaline same thing, NS will, but one more thing you should remember is dextrose. In the ward case, I am telling, not immediately newborn. And one more drug that I am missing, which I am not mentioned in this slide. Anybody can point out that? Which is commonly used? Oxygen. Oxygen is a drug. Okay. The preterm in units, oxygen is a drug. Okay. Madam already explained about it, how much to start and so that should also be used very meticulously, especially in a preterm child. Okay. This is all about the adrenaline and NS. Okay, what's the dose of adrenaline? IV? ml per kg of 1:10,000 dilution. When you give adrenaline? When? I told 4 things. Heart rate below 60, After effective positive weather ventilation, followed by effective chest compression with 100% FiO2 for more than 60 seconds. Okay, that's the indication of adrenaline. You know how to prepare it, label it without fail. Then UVC thing, intraosseous and ET, you know that. Okay, this is all about medications that people should remember. Only two, but very important. Huh? Chalo, thank you.
Have you? Yeah.
Usually, first to get O negative, like I said before, it takes almost 24 minutes before you get into that part. Okay, take it on more 2 minutes and stuff, 6 minutes something. By then going to blood bank, current will get into it's very
Okay, next we have Dr. Karambir Singh Gill, who is Assistant Professor of Pediatrics and Neonatology, Dayanand Medical College. Welcome, sir.
Good morning to all present. Am I audible?
Yes, sir, you are audible.
The slides are visible?
Yes, sir, it's visible. You can start, sir.
Are the slides visible? Shall I start?
Yes, sir, you can start.
Yeah. So, good morning to all present. It is my honor and privilege to be part of this NeoCon 2021 through the virtual mode. I extend my warm regards to all the faculty members and nursing staff and the nursing officers who have joined us today. The topic given to me was the identification of the sick neonate. Now, identification of sick neonate, I have tried to cover it in the postnatal wards, in the ICUs, or including in the emergencies. So what is the scope of the talk today? I have tried to cover that why is it important to identify a sick newborn or a child, how to identify a sick newborn, what are the parameters we use for the assessment, and what are the vital parameters that you need to memorize age-wise, and what are the routine assessments we should be doing in our routine postnatal rounds, or how to identify sick neonates in the neonatal ICUs. Why is it important to identify a sick newborn? In a sick child, the child is not going to give you much time for the resuscitation, so you need to identify the kids with emergency signs immediately. There are usually 3 types that we identify a sick newborn or a sick child into. Some of them have the emergency signs, so they need immediate emergency treatment. Some of them have priority signs which need rapid assessment and treatment, and some of them are non-urgent where we can wait and do the careful observation. Now these are the 2 pictures taken from my neonatal unit. So one is picture A, it is a term baby. Now this baby has been with us for 3 to 4 days and the baby has been kept NPO, versus picture B, which is of another term baby. So we will discuss at the end of this talk that just by looking at these 2 babies, out of A or B, which one is looking sicker and which one is looking stable. So there is an assessment triangle which is used world over. This is called PAT assessment triangle. You can memorize it by the word PAT. There are 3 components of this assessment triangle. It is appearance, work of breathing, and skin circulation. So what is appearance, or A stands for? Appearance is that how is the activity of the baby? Is the baby moving around? what is the tone of the baby? So if the baby is active, baby moving around, and baby has a good tone, that is a stable baby. But if the baby is not active, baby is hypotonic, that is a sick baby. You can look for crying in a newborn, and in a bigger child, you would look for how responsive is the child. So if any of these parameters you are able to identify is abnormal, that means your baby is sick. After appearance, we go to B, which is your work of breathing. In work of breathing, for a newborn, you should always look for that is the breathing pattern of the baby normal? How is the respiratory efforts of the baby? Is the baby breathing too fast? Is there any added sounds while the baby is breathing? Is there any stridor or wheezing? Are there any chest retractions? If any of these are present, that means your baby is sick. Third component is C, which is your circulation. So circulation would mean that how the skin of the baby looks like. Is it mottled or is it looking pale? If it is mottled, it means you have cutaneous ischemia and the baby is sick. If it is looking cyanosed, you should look that whether the cyanosis is only in the peripheries or it is even on the lips or the tongue of the baby. So remember this ABC, which is appearance, breathing and circulation. These are the parameters which we assess from a distance. We have not touched the baby, we have simply looked at these three parameters and the baby is sick. So after this primary assessment, breathing, circulation,
with the
yeah, thank you. So after the primary, we go to the primary assessment, which is the airway, breathing, circulation. Now these are the respiratory rates which are for a newborn. If the respiration is more than 60, that means the baby is having tachypnea, and subsequently as the age advances, the respiratory rates they keep on decreasing. We come to the third parameter, which is C, for circulation. Now in circulation, you should always look for heart rate, and in a sick newborn, always look for rhythm. So heart rate and rhythm both should be assessed simultaneously. You should always look for your pulses, which will be the central pulses as well as the peripheral pulses. In the central pulse, you can feel the femoral. For the peripheral pulses, you can feel the radial. What is the CFT? So you can check the CFT on the interior part of the chest. Normally it should be less than 2 seconds. What is the skin color? Is the baby looking pale or cyanosed or mottled? What is the temperature of the baby? And what is the blood pressure? So if any of these parameters is abnormal, that would identify that our baby is sick. So what are the usual cutoffs taken for the heart rate? In a newborn, we usually take a cutoff of 180 as tachycardia and less than 80 as bradycardia. And in a bigger baby like 1 year, the cutoff will be 160 for tachycardia and so on. For blood pressure, we take for a term baby, if the systolic blood pressure is less than 60, that would be taken as a sign of hypotension. And for a baby who is 1 year old, the cutoff of 70 is taken, which will be the sign of hypotension. So these are the BP charts you can use in your units. They are available on IAP websites. So they can help you identify the blood pressure depending upon the age, right from the age 1 year to 15 years. Next is the component D, which is disability. Now in a newborn, when we are talking about disability, it is important to assess the level of consciousness of a sick child. So the child may be sleepy and awake, but if the child is awake to your responsiveness to your voice, that will be known as the ABPU scale, where we will say that the child is responsive to voice. But if we have to pinch the baby for the response, that will be called as responsive to pain, and unresponsive will be that the baby is not responding even after the painful stimulus. So while we are doing the assessment on ABPU scale, simultaneously you should look for the blood sugar levels of a sick baby. This is very important for a newborn because they may turn lethargic, and you might find that there was inadequate feeding preceding to that and blood sugars have dropped. And in a sick child, always look for your pupils. So these are the components you look in D, which is disability. That is your level of consciousness, pupillary response, and blood glucose levels. So in the ABPU scale, the score of 6 as far as GCS is concerned will be for a child who is unresponsive and a child who is responsive to pain. So any child who is in the score of P or U will be taken as a sick child. So this is the GCS chart. You can use it for the bigger children after the non-neonatal period. Next component is E, which is exposure. Now exposure means you have to see your baby head to toe. You look for any petechiae, purpura, rash or mottling. And if you find anything abnormal, you have to identify that this is a sick newborn. So this is the conclusion of our assessment which we have done so far. So first is our PAT assessment. You look for A, B, C, which is your appearance, work of breathing and circulation, followed by primary assessment, which is A, B, C, D, E, which is airway, breathing, circulation, disability and exposure. Now we come to the secondary assessment. So once you have done your primary assessment and you have come to the conclusion that my baby is sick, you should simultaneously look for sample history, which means what were your signs and symptoms of the baby. Allergies will not be relevant here for a newborn. Medications, that was any medication given to the newborn. Past medical history is an important point here because you may have a baby who was born through perinatal asphyxia, but mistakenly you shifted the baby mother side, baby turns lethargic after a few hours, so it was important to review your birth history in the past medical history. Last meal for a newborn would mean that when the baby had taken feed, was burping done adequately, and what were the events that led to the illness. So this thorough assessment will be done simultaneously while you are preparing to shift your sick child to the NICU. So this is the assessment triangles which are available online. You can use it in your units. Now we have covered the major components that how you are going to assess your sick newborn. Now we will discuss that how can we use it in our day-to-day practice. For example, we are doing our journal postnatal rounds. You should always look for the journal appearance of the baby. That is the baby looking well? Is the baby looking around? Is the baby feeding well? And is the baby active? Then it should be followed by head-to-toe examination done at least once or twice in 24 hours. You should look for feeding adequacy and feeding position. You should always ask how many times the baby has taken feed. Is the latching proper? Always examine your umbilical area for any swelling, redness. Always look for your jaundice because in certain cases jaundice may be apparent within first 24 hours as well. Touch the baby and you can monitor the temperature through your thermometers. Look for any mottling. You should be asking that how many times the baby has passed urine and stool, and daily weight of the baby should also be done. Now while we are looking for these signs, there are certain things which should warn us. For example, if there is cyanosis, grunting, fast breathing, chest indrawing or floppiness. So all these parameters we have discussed in our assessment, which will be your primary assessment and your PAT assessment. Now what happens when we encounter an emergency situation in our postnatal wards or step-down units or neonatal ICUs? So now we are talking that there is a stable baby who was in the postnatal ward, but suddenly the baby has deteriorated. What to do? Now we will assess the baby on the same parameters that we have discussed so far. For example, our baby is not breathing or the baby is gasping, heart rate has dropped, baby has turned blue. So that means our baby is in a respiratory failure. So we are immediately going to start the baby after assessing the parameters. Open the airway, start with bag and mask ventilation, put oxygen to your bag and mask, shift the baby into the warmer and plan to shift the baby to NICU. In case your baby has tachycardia with pallor, lethargy, unconsciousness and peripheral and central pulses are weak or feeble, you are dealing with probably a case of circulatory failure. Immediately assess your baby, prepare to shift to NICU, put an IV line, start on oxygen. You may need to keep the baby in the warmer till you shift to NICU. Check your sugars, can give a D2 bolus if there is hypoglycemia. If you encounter a baby who is hypoglycemic, sugars are low, baby is lethargic, secure an IV access, supervise your feeding or give a D10 bolus. Now there may be situations which are not emergency but priority. For example, you have a baby who has not been breathing occasionally, but breathing in between is looking well. So you should take it as seriously because baby may be throwing apneas. Stimulate the baby, shift to NICU, you may need CPAP support, send your sepsis profile, get your labs done and accordingly if needed, start on antibiotics. In case the baby has severe respiratory distress, there is severe chest and groin present, grunting or tachypnea, you may need to shift the baby to NICU immediately, prepare to start oxygen or CPAP, get your X-ray and plan to start antibiotics. In case you have mild respiratory distress, for example, your respiratory rates are 60 to 80, you may monitor the baby in the postnatal ward, put on O2 by prompts, check your SpO2s and observe the baby closely. In case you look for that the baby has a central cyanosis, but your oxygen saturations are dropping down, but there are no chest retractions, no grunting. So you may need to shift the baby to NICU and rule out a cardiac disease. So what are the red flag signs in a newborn? Any temperature instability, temperature less than 32 or more than 38, baby is not feeding well, decreased muscle tone, irregular movements or convulsions, baby is lethargic, baby is repeatedly vomiting, abdominal distension or jaundice in the first 24 hours. For example, you had a mother who was diabetic and your baby was weighing more than 4 kg, we should have anticipated hypoglycemia. So monitor your baby for bilirubin or clinical icterus within 6 hours of life. If you have a mother who had a prolonged rupture of membrane for more than 18 hours or any history of maternal fever or offensive smelling liquor, always suspect the possibility of bacterial infection, watch your baby closely and you may need to start antibiotics. If your baby had low Apgar scores at 5 minutes, you should be watching for neonatal encephalopathy, so observe your baby closely. In your postnatal rounds, you may encounter mild problems like local infections, which can be in the form of conjunctivitis, pus blisters on the skin, or onphalitis. So they need to be treated accordingly. In some cases, you need local antisepsis. Now, we may encounter some serious acute infections in the newborn in the postnatal units or the step-down units. You may have a baby who is turned lethargic, is feeding not adequately, there is abdominal distension, jaundice, apnea or hypothermia. You should immediately suspect sepsis and do your sepsis profile and may need to start ampicillin gentamicin. You may have a baby who is throwing repeated apneas, had a seizures, and on examination your interior fontanella is bulging, rule out meningitis and you may need prolonged antibiotics. You may have a baby who is preterm with borderline sepsis, past blood and stools with bile-stained vomiters. Immediately rule out NEC, get your sepsis screen done, get your abdominal x-ray done, and you may need to start antibiotics and observe the baby closely. Feeding assessment is a very important part of your postnatal units. You should always see that is the baby able to attach properly. There will be 4 signs of good attachment. The chin should touch the breast, the mouth should be wide open, the lower lip should be turned outwards, and areola should be visible above. You should always look for these signs while you're doing the postnatal rounds. Always look for the positioning, and if the baby is not feeding well, look for the oral thrush. Now there may be a baby who is not able to feed at all, which means the baby has no attachment and no sucking. Check your vital parameters, send your sepsis screen, and you may need to shift the baby to your neonatal unit. There may be a baby who has a feeding problem, but the baby is having attachment intermittently, but the feeding frequency is not normal. So you may need to correct the positioning and the attachment, counsel the mother, but observe the baby closely. In case you have a baby who has a poor weight gain, you should always emphasize the steps of attachment, positioning, feed volume that you're giving to the baby in case of a preterm baby. Is mother doing KMC accurately? And counseling is an integral part of your management. Now this we have covered, that how are you going to assess a sick newborn in your emergency. So in conclusion, you should always look for your PAT assessment, do your priority assessment, identify the sickness early, document whatever vital signs you're observing are abnormal, and counsel the parents.
Excuse me, sir. Karan,
thank you so much.
So can you repeat from the slide where you're showing the NICU assessment? We lost connection at that time.
Hello.
Hello, can you hear me, sir? Karanbir, sir, can you hear me, Dr. Karanbir? Unmute करो. Hello, Karanbir, sir? We are muting. Dr. Karanbir Gill, can you hear me?
Yes, yes.
So can you please repeat from the slide where you were showing the assessment of NICU area, NICU assessment slide. We lost a connection at that time.
Okay,
yeah,
sure.
Please.
I'll get back. So this is the second last slide only. So should I repeat the whole slide?
Yes, sir.
Okay, yeah. Okay, so basically we are doing the assessment for the vital parameters in the NICU. So there is heart rate monitoring, respiratory rate monitoring, temperature, CFT along with your peripheral pulses. It may be non-invasive or invasive blood pressure monitoring, SpO2 monitoring, RBS as per the protocol, and you should be documenting the feeding, which may be in the form of OG feed, spoon feed or breastfeed, urine or stool frequency, color of the baby, is the baby having jaundice or requiring phototherapy, what is the abdominal girth, and if there are NG aspirates, you should document. KMC, is the mother doing KMC, and how many maternal visits are there in 24 hours. And in any baby who is having respiratory distress, you should document that is the baby requiring CPAP or HFNC, and if yes, what are the settings? They should be documented on the charts. For example, in CPAP, you should note down your FiO2 and P. In HFNC, you should note down your FiO2 and flows. In case the baby is ventilated, document your mode, which is your PIP and P, what is your P time, what are your rates, what is your FiO2. You should always note down whatever infusions are ongoing and whatever drugs are ongoing, because they will be an integral part of your intake output ratio, which you should be calculating every 6 hours for every newborn. Now, how to identify sickness early in a newborn in NICUs? Any fluctuation of more than 10% in the baseline vital parameters should be taken seriously. For example, you have a baseline heart rate of 140 and suddenly your heart rate has jumped to 160 or 170. You should take it seriously and observe your baby closely. Now, you may have a baby on ventilatory support and suddenly the baby has deteriorated. So, for sudden deterioration of a ventilated newborn, always rule out the mnemonic called DO, where D stands for displacement, which means you check your air entry, your ET tube might have got displaced. Look for any obstruction, your ET tube might have got obstructed, so do the suction immediately. Pneumothorax, you can check it by the cold lights or the trans-illumination in your units. You may get a chest X-ray immediately, and these days we have the ultrasound machines in most units and fellows can immediately do the point of care ultrasound. E stands for equipment failure, which means your ventilator is not working. So immediately take the child an ambu bag and check your equipment accordingly. So these are the two pictures we were shown in the initial part of our session. So the picture A versus picture B. Now, based on our assessment which we have discussed so far, what is the difference between these two term newborns is that the one in picture A, the abdomen seems a little tense, whereas in the picture B, the abdomen looks normal. This baby is looking sleepy or lethargic, whereas this baby is in a bit of a crying here. There is a RT aspirate which is going on here in the picture A. There is a greenish bile stained aspirate, whereas in picture B, there is nothing like that. In picture A, we have the baby on O2 prongs, and in picture B, the baby is not on oxygen prongs. So if I have to identify that out of A or B, which is my sick baby, I would go for the option A, and the B baby looks like stable. So how to conclude? The most important thing is that we should be doing our PAT assessments in our day-to-day practice, followed by our primary assessments. You can remember the mnemonics ABC followed by ABCDE. Always identify your sick newborns early, because early identification will help us. Document whatever abnormality you are observing. For example, you have a low sugar, please note it down on the charts, and always counsel the parents accordingly. So that's all. I would like to conclude the talk. Thank you so much.
Hello, can you hear me, sir? Thank you for the wonderful session and explaining PAT triangle, primary, secondary assessment, and what are the, how to perform the meticulous assessment of a neonate who is admitted in neonatal intensive care unit. And now the floor is open for the discussion and questions. So participants are requested to ask the questions. If there are any queries, you can clarify, please. You have a question? Sir, we missed one slide. Which slide you missed? The slide which is before the wedding. Sir, they have missed a slide. Huh? That's a graph. They have missed a slide that. You just tell me.
So good morning, sir. We need the slide before routine care in NICU, sir. That's a graph one, sir.
Routine care in NICU?
Before that.
So they are saying that they have missed a slide before the routine care. There you have shown a graph.
Okay.
Yeah.
I can. Okay. That was the sample history, right? You want me to repeat that?
Yeah.
Okay. Can I share it?
Share the slide, please.
Okay.
Okay, you share.
This one?
Not visible, sir. Please share the slide.
1 second. visible?
Yeah, this one they want to see.
Is it this one they want to?
This one? Yeah, this one they want to see. You want to take a photograph, I think you can take.
Okay, I can share the presentation on the group also.
Yes.
Yeah, I'll do that. So this is basically the PAT assessment which I have explained in this entire talk. So based on our assessment of the primary assessment of airway, breathing, circulation, visibility and exposure, we will identify that whether our baby has a respiratory issue, circulatory issue or a neurological issue. So we are going to identify the baby and work accordingly. For example, if we have a respiratory issue, we may start the baby on oxygen, CPAP or ventilation if needed. If we have a circulatory problem, you may go for oxygen, IV bolus, inotropes if needed. And if you have a neurological issue, you may need to go for intubation, check your glucose and work accordingly. And sample history is also a part of this assessment triangle. So this is a standardized assessment which we are using. It is the part of one of the PICU protocols published in 2016. So I'll share it on the main group. Shall I stop sharing?
Yeah, you can stop sharing. Thank you for the wonderful session. We enjoyed it.
Thank you.
And I hope our participants will be able to translate the learning into their clinical setting. Thank you, sir.
Thank you so much.
Okay. So now I invite Dr. Poonam Joshi to introduce our next speaker, Dr. Kiran Raghu. Please display the CV slide of Dr. Kiran Raghu. Poonam ma'am, can you hear me?
Hello. Yes, I can. I hope I am also audible to you.
Yeah.
Hello.
Yes, ma'am, you are audible. CV slide.
A very good morning to all. And it's my proud privilege today to introduce Dr. Kiran Raghu. Dr. Kiran Raghu is going to talk about pain management in neonates. Till many years ago, we continue to thought that neonates, they don't feel and experience pain, or if they feel, they tend to forget. But these were many myths we had, and now a lot of work has been done in the area of pain and stress management in neonates. So for this, we have Dr. Kiran Raghu with us. Dr. Kiran Raghu, he is currently working as a consultant neonatologist at Kaveri Hospital, Bangalore. Dr. Kiran has been graduated from JJM Medical College, Devnagari, and completed his MD from Medical College, Mumbai. Thereafter, he did his DNB from Chennai. It's Kachi Kamakoti Child Trust Hospital. Dr. Kiran Raghu has mainly some important areas of interest, that is neonatal care of extremely premature babies and infection control and perinatal counseling. He's right now working as a consultant neonatologist at Kaveri Hospital, Bangalore, and prior to this he had worked in various capacities in other prestigious institutions. So I invite Dr. Kiran Raghu to deliberate on pain management in neonates. Over to Dr. Kiran Raghu.
Thank you, ma'am, for the introduction. I thank Neocon for giving me this opportunity to present at this workshop. And the topic that is given to me is pain management in neonates. This is something very important when it comes to care of newborns, but is also something that we don't take it very seriously. So by definition, pain is an unpleasant sensory and emotional experience which can be associated with actual tissue damage or has the potential to cause tissue damage. So it is probably the most common symptom any patient experiences in the hospital. So all the more the reason that we need to take pain very seriously. So is the NICU environment painful? Okay, it's a question that I want to ask everybody who is here. So what do you think, the sisters who've been working in the neonatal intensive care wards, do you feel that the NICU environment is painful? It's not painful. Okay. So actually the answer is obvious. Yes, it is painful. Okay, the NICU environment is very painful. I'm not asking about whether it's painful for you. The question was whether is it painful for the newborns. Yes. So it is, the answer is obviously yes. NICU environment is very painful for the newborns. The thing is, we need to remember this question each day when we enter the NICU. Each shift when you enter the NICU, that we need to remember that, you know, the NICU environment is painful for the newborns. This is just a few things, few procedures which a newborn baby undergoes. You know, I can't put the entire list here, but it's. I'm sure a newborn baby will undergo 2 or 3 times the number of procedures, a sick newborn baby especially. So definitely, it's you know, quite a lot to deal with for these babies. So can newborns feel pain? Do you think the newborns feel pain? Yeah, definitely, yes. So basically, the neural pathway, which is called the spinothalamic tract, which is responsible for transmitting pain in anybody, newborns or adults. So this pathway is intact and it's functioning to its fullest capacity during the fetal life as well. So that is why we see, if at all a mother hears a loud sound if the baby is inside the womb, the baby reacts by kicking. So when the mother hears a loud sound before delivery, before the birth. So the reason why, if somebody taps on the uterus, the baby kicks back. That's the reason. The reason being the spinothalamic tract being intact, and so the baby can feel pain not even before birth. That's not going to the next slide. Next slide, please. So they feel the pain just like as we adults do. Next slide, please. So the only problem is, they cannot actually express where the location and how severe the pain is. So all the more the reason why we need to pay clear attention, so that the pain does not go unnoticed. So babies not only feel the pain, they will remember it too. Just remember, they remember it. The pain means, it changes how the babies perceive pain in later life. The babies are experiencing pain for a long time in the NICU.
Recording in progress.
So these babies, they may become hyperactive in later life. They may develop an exaggerated response to pain in later life, or they may become overtly sensitive to even very routine handling or a less painful stimuli. Often we see some babies who are you just touch the baby and they cry. That's because of the pain experienced over a very long time, these babies become overtly sensitive to pain. Next slide, please. Okay, coming to the effects of pain, there are short-term effects and long-term effects of pain experienced by these newborns. The first three, things like the heart rate, respiratory rate, and the BP fluctuations in all these parameters we see in acute painful procedures. Heart rate going up or reducing, respiratory rate, baby either becomes tachypneic or becomes apneic, and fluctuations in BP. These we see in acute painful procedures, something like a heel prick or an IV cannulation or a blood sampling. But if the pain is of more chronic duration, many days of pain or very severe pain, it's not the simple heel prick or something. These can be associated with increase in cerebral blood flow. Also associated with hypoxia and hypercarbia. So when the pain is of severe, the severity is very much high, and if the pain is of a longer duration, these can cause, especially in the extreme preterm babies, it can cause IVH, even in the initial few days or in the later weeks, which is also associated with white matter injury. So coming to long-term effects of pain. There's these same babies, when they grow up as children or as young adults, they may have increased anxiety, they may have increased pain sensitivity, And they may also have a whole lot of other neurological deficits like, hyperactivity, attention deficit, cognitive deficits, behavioral impairments, and poor socialization skills. So definitely, better pain management leads to, better neurodevelopment in the babies. So before we know how to manage pain effectively, we need to assess pain. We need to know whether, the babies are really experiencing pain and how severe the pain is. So basically we look at a few things in the baby, the facial expressions or the way a baby is, the posture of the baby, and a few things that we look on the multipara monitors, the changes in the heart rate, the changes in the saturations, the changes in the respiratory rate. So these are the things we use for assessment of pain in neonates. So there are a few biomarkers, which I'll go into in the next slide. There are a few behavioral changes in the baby, and there are a few pain assessment tools, or you may simply call it the pain scales, so which are there to assessment of pains. So other things like EEG, NIRS, and functional MRI, these are basically to understand the implications of pain on the central nervous system, on the brain. So coming to the biomarkers, so these are the physiological and neurophysiological reactions that are seen following pain. So the blood pressure and heart rate may either increase or decrease. There's something called as heart rate variability. So does anyone know what is heart rate variability? What does that term mean, heart rate variability? Yeah, so is it a good thing or is it a bad thing, variations in heart rate? No, wide fluctuations in heart rate is bad. Suppose a baby has a heart rate of 140, if it goes down to 80, 90 and then comes back to 140, then it's bad. What I'm saying is heart rate variability means if a baby having a heart rate something between 130 to 150. It just keeps going. When the baby is active, it goes up to around about 150, 140. But when the baby is sleeping, it comes down to around 120. So that is a normal heart rate variability, which is a good sign in babies. That's very reassuring that the baby is fine. So, but when you see a baby having a fixed heart rate, something in the range of, some 150s or, 160s, irrespective of what the baby is doing. The baby is active, it's still 160. The baby is quiet, it's still 160. So the loss of heart rate variability indicates that the baby is experiencing some pain. Or it could also be indicative of some other disease state like sepsis. So loss of heart rate variability. So decrease in heart rate variability is indicative of pain in newborn babies. So other things like intracranial pressure can be increased. Oxygen saturation definitely decreases. The respiratory rate, babies can either become tachypneic or they may become apneic, especially in preterm babies. The skin color can either change. They may become excessively red, or they may become pale, depending on how the heart rate and the respiratory pattern is. So these are the behavioral changes that you see in these babies. The babies may, avoid making eye contact, or they just look away. There are some typical facial expressions which we see in these babies. This slide, the eyes may be tightly closed, the eyebrows may be drawn down, and you see something called as a brow bulge in between the eyebrows whenever the baby is experiencing severe pain. The mouth may be, widely open. We call it squarish mouth. The nasolabial folds, which are deepened in such babies. There's also raised cheeks and broadened, bulging nose. So these are the facial expressions which are seen in babies with those who are experiencing pain. Coming to changes in the pattern of the cry, both the duration and the pattern of the cry can change. They may become increasingly fussy, or very often we see something called a silent cry. Babies might have experienced pain for so long duration that they may just have lost all their energy sources and they're unable to even cry vigorously. They just cry silently. We can't even hear them cry. So there may be abnormal limb movements, like fisting or fingers playing. They just open up the fingers when they experience pain. Muscle tone can be increased or decreased. There's also alteration in the both in the duration and the quality of sleep in such babies. So these are the behavioral changes that we see in babies. There are quite a few pain scales which are used for assessment of pain in newborns. Of these, I'd like to focus on two scales. The first being the premature infant pain profile. This is one scale which is actually validated even for use in preterm babies. There are other scales like cries, comfort scale and neonatal infant pain scale. I'll just be focusing on 2 scales in the next few slides. So this is the premature infant pain profile, which can be used even in preterm babies. The various parameters that are seen in change in heart rate and change in oxygen saturation. And you also see the duration of some facial expressions like brow bulge, eye squeeze, and nasolabial furrow, how long the duration exists, and based on that you give it a scoring of 1, 2, or 3. There's also scoring for gestational age. This is the one thing which is there in this particular scale. You don't have scoring for gestational age in other scales. This is scoring of 0 to 21. The minimum score is 0 and the maximum score is 21. The higher the score, the greater is the pain behavior. These are the scoring instructions which you can get if you just probably search for this particular pain scale. This is a simpler scale, neonatal infant pain scale. There are fewer parameters which can be used and can be done quickly than the previous scale, but this can't be used in a preterm baby. Again, higher the score, the more is the severity of the pain. So basically there are many scales which are there for assessment of pain, but whatever you use, it must be valid and it must be reliable. That means whoever does it must be able to get the same the scoring. It should be easy to score. So once you assessed pain, then you'll be able to manage pain more effectively, and there are some general principles for pain management. So basically any procedure which is painful in adults should be considered as painful even in newborns, even if they are preterm. So basically newborns actually experience a greater sensitivity to pain and are more susceptible to long-term effects of pain. So when you treat the pain adequately, definitely it is associated with decreased clinical complications and as well as mortality and morbidity. So there are multiple modes of managing pain. If you use these different modes effectively, you can actually reduce or even eliminate neonatal pain. And one important thing which I marked in red is just giving midazolam is not enough for pain management. So I made this mistake myself during my initial years of residency. So whenever a baby is fighting on the ventilator, crying on the ventilator, we give midazolam thinking that it reduces the pain. But midazolam will just make the baby sleep, but it can continue to feel the pain. It just masks the baby's response to pain, but it actually does not eliminate pain. So it has to be combined with other agents like fentanyl or morphine for effective pain management. Only midazolam is not an effective pain management drug. So each unit should have written guidelines and protocols for effective management of neonatal pain. So this slide shows a step ladder approach to management of pain. I think the most important part of this slide is the very first step, that is the baseline. It is important to, the first thing in pain management is prevention of causing pain for the babies. Okay, so in preventing pain, you avoid painful procedures as much as possible and do it only when it is indicated. And you need to give clustered care for the babies as much as possible. So the blood samplings have to be adequately planned. You avoid repeated pricks. If baby requires blood sampling to be done on a particular day, you make sure that it's done on one particular time. You don't repeatedly prick the baby on that particular day for. So, and also use of non-invasive tools like transcutaneous bilirubinometer for assessing jaundice. So I want you to concentrate on the stars that are on the right side. The glucose, the breast milk, which can be used as a non-pharmacological method for relieving pain. Other thing is, as in a step 3, we use paracetamol for slightly more severe, well, I would say a moderate pain. It's not very severe, but moderate pain can be treated very effectively with paracetamol. So other drugs like fentanyl, morphine, these are all indicated in very severe pain, and definitely the doctors will give you the orders for starting these particular medications. So I'll start with non-pharmacological management of pain. So this is, I think the slide is self-explanatory, clustered care. So that means grouping all your interventions that you do in a baby in one point of time. Like this as an example, you finish off all these things in a half an hour period. Checking the weight, the nappy change, the sampling, and then the feeding. The same thing, if you do it in blocks of, if you check weight at 6 a.m., then you do a nappy change after 15 minutes, then you do sampling. If you don't do it in a proper fixed time, you end up disturbing the baby more and more often, which is not good for the babies, The second non-pharmacological tool is the environmental modification. This is basically for the better sleep of the babies. The light has to be, adjusted adequately in the NICUs. Avoid some bright lights which are, pointing directly at the baby's face. Always use procedural lights. Have a standby light which can be used for procedures, which can be directed only at the place where the procedure is being done. So if it's a central line, just focus it in the place where the central line is being placed, instead of the entire baby being the head and the eyes being exposed to the light. So units also practice cycled lightings. Lights are on during some time of the day and they are dimmed in other times of the day. Do you practice that in your units? Cycle lightings? So the lights are on during some time and it's dim during the next periodically. Okay, so that is something which is good for the baby's overall sleep and development. If you have dim light in the NICU for some time, provided you continue monitoring the baby's other parameters. You may have to switch on the lights to see how the babies are, but it's good if you keep the lights dim for at least periodically for a few hours in a day. Also minimize sound levels. It's not just the alarms, which keep buzzing around, very loud alarms. We need alarms because, that's how we can get to know when there are lots of babies. So make sure that the alarm volume is properly adjusted, that it's not very loud. And it's not just the alarms, just the bedside conversations, the rounds that you take next to the babies, the handing overs that you give next to the babies, all has to be done in a quiet way or probably a little away from the babies. That itself can increase the sensitivity to the babies. So did anybody notice a change in this previous slide? Yeah, it is purposefully made less brighter so that you remember that, this is, this is purposely done less brighter so that you remember that, cycle lighting is good for babies, okay? Yeah. Mobile phone ringing, yes. Mobile phone ringing, make sure that, it's not very loud. So the next one is swaddling and facilitated tucking. Swaddling is just making sure that the baby is kept covered, wrapped well. This is a picture which is depicting facilitated tucking. Okay, this is a facilitated tucking in the side-lying posture. We can do it in either the supine posture or in the side-lying posture. Basically, what you need to do is you need to make sure that the head, the upper limbs, the lower limbs, and the trunk are all in a flexed way. In this picture, you see soft cushions that are in the shape of gloves which are supporting the baby's head, the back, the trunk, and the legs. Basically, this is the position which the babies will be in when they are in utero. They will be flexed. So that's a very comfortable position the babies feel in this position. Kangaroo care skin is an effective way of reducing pain in babies because they release hormones that increase the pain threshold. So other methods are non-nutritive sucking, where the baby is allowed to feed on an empty breast, probably during the procedure or immediately after a procedure. There are units which use oral sucrose 24%. It's not very easily available in our country. There are some hospitals where they get it from their own pharmacy. There are studies which have used glucose to 25% dextrose instead of sucrose 24% because of its non-availability. And I came across this particular study from, this is from LHMC, where they used dextrose 25% instead of oral sucrose for managing pain. And when they assessed pain by the PIP score, they found that both gave similar the pain scores, whether they were given 25% dextrose or 24% sucrose. So music is also another good non-pharmacological method of managing pain. You can use classical music or the mother's own voice recordings. And the family can have their own voice recordings which can be played probably in a phone or something. there's something called as white noise. This is the noise that we make whenever we carry a baby. We always say shh. That's called white noise. The sound of wind blowing or sea waves. That itself is a very good way of making the babies calm. Can you play this? Just play this. Adu mele click ಮಾಡಿ. Just click on it. Just go back and you'll find a play. No. Minimize the escape. Press escape. Yeah, just play there, and then you maximize. Okay, fine. Okay, this was a video courtesy AIMS. There were many methods of non-pharmacological management. So we'll go to the next slide, no problem. Okay, go to the next slide. So there is another thing called a sensorial saturation. Basically, you mix all possible methods. Like you look at the baby, you talk to the baby, you make eye contact, you massage the baby, you probably put a dextrose gauze into the baby's mouth. So you mix many different modes of management at one particular time during the procedure, so that all things are having its own its effect on the baby. That will make sure that the baby gets maximal analgesia during the procedure. Coming to pharmacological management, there are. I've been reading about this, eutectic mixture of lignocaine and prilocaine. It's called as EMLA. It's available as a cream which can be used on the place where you're pricking the baby. So it's not easily available in our country, and it's not recommended routinely for use because they are associated with other side effects. So I'm just mentioning it here. Lignocaine is something which I think we should use. We do a lumbar puncture is a very common procedure that we do in babies, and we don't use lignocaine before a lumbar puncture. Ideally, we should be using lignocaine before each lumbar puncture. There are systemic medications for severe pain, like paracetamol, which is a non-opioid, and opioids like morphine and fentanyl. These are definitely to be used when babies are experiencing severe pain. Obviously, these medications has to be used only when indicated, and its prolonged use has its own side effects. So a few points to remember. I think the first one should be the non-pharmacological methods. It is a very important way of managing pain in babies. The few things that we listed earlier. Paracetamol is a safe drug, can be used at a dose of 10 to 15 mg per kg, either oral or IV. Morphine and fentanyl used sparingly when definitely indicated. Using only midazolam is not a good option for managing pain. So this is again the same step ladder management of pain. So the most important ones are the non-pharmacological methods like non-nutritive sucking, oral sucrose or glucose, breastfeeding, swaddling and facilitated tucking, and skin care. So you can use paracetamol for post-op or post-procedural pain, for babies having abscesses or wounds. These can be easily managed with paracetamol. So just like to end this talk with with a myth and a truth. Thank you all.
Thank you, Dr. Kiran Raju, for comprehensively covering this topic. Dr. Kiran has told us that pain, neonatal pain, it can be assessed. We can identify the pain by paying attention to the behavioral cues, the changes in the physiological parameters, and the autonomic changes. So this is an important researchable area. I'm sure we have MSc nursing students. They can tap this area for their dissertation purpose. And we have to, as nursing personnel working in the neonatal ICU, we have to identify the painful procedures and accordingly we have to take all the measures to comfort the baby. As Dr. Kiran said that there are general measures, then there are non-pharmacological measures. So rather than depending on pharmacological measures, we should try to make more and more use of the general measures like avoiding bright light, comforting the baby, swaddling, and the non-pharmacological like breastfeeding, skin-to-skin contact, and the non-nutritive sucking. So with this, I keep the floor open for discussion. If you have any questions, please do ask.
So what we can do is we can we can identify the best tools. We can paste them at the back of our charts, and we can put the dates in serial so that they start assessing the pain. So this is how we can sensitize them and we can operationalize this. So we conducted it and we improved up to 35%, not much in first go. Second, we operationalized the use of non-pharmacological measures in our setup. So when we did the pre-assessment, we found only 3% of the nurses or the residents, they were using the non-pharmacological measures like facilitated tucking and swaddling. It's so easy to do. You have to just hold the hand of the baby, flex the legs before the heel prick or before cannula insertion, but only 3% of them were doing. So we operationalized, we again improved up to 33%, and we are still trying to improve this practice in our setup. So we need to think of ways. Getting knowledge is not enough, but translating the same into the practice is more important. So we need to think how we implement them in our setup to use them, make maximum use of these measures. So that's all I want to say. Thank you, sir. Okay, for next session, I invite Manisha ma'am to kindly moderate the session.
Thank you, Gitanjali, for your inputs.
Thank you, ma'am.
I really appreciate the work done by you.
Yeah.
Thank you.
Okay, thank you, ma'am. Thank you for joining us. Please display.
Our next speaker is Dr. Shriyan Ashwij. Dr. Shriyan is going to be delivering his speech virtually. He's there. He's joined. Hello, Dr. Shriyan. You can hear me?
Hello.
Yeah. Can you hear me?
Yeah.
I'm Dr. Manisha.
Yes, ma'am.
Yeah.
Yes, ma'am. Yes, ma'am. Yeah.
Okay.
Thank you, ma'am. Thank you for the wonderful.
Yeah. So I'm just going to introduce you. Please put his introduction slide. So he has done his MBBS from SSMC Tumkur Hospital, Medical College, and his MD from Dr. D.Y. Patil Medical College. And he is, Dr. Shriyan, he has done his fellowship in neonatology from Bharati Vidyapit, Pune, and presently he is assistant professor at Mangalore HIMS Hospital. He has been IAP secretary for Dakshin Kannada from 2014, 15, 16, and has worked as with the responsibility of a treasurer, and he had been IAP joint secretary of Karnataka State for the year 2021. He is a basic NRP instructor and state coordinator for the same. So we welcome you, Dr. Shriyan, and you can please start with your talk.
Yeah. Thank you, ma'am. Thank you for the wonderful introduction. I think this is a wonderful session where we are having, conversing with this nursing staff who are the main backbone for any NICU care. So going on to my session, we'll directly jump on to the slide. Okay, we are dealing with the nursing management of HI on therapeutic hypothermia. So most important is knowing the clinical criteria. That any babies which are more than 35 weeks of gestation and less than 6 hours of post-birth with any evidence of asphyxia, which can be defined by, I think the slide is coming up. Yeah. Can you put on the slides?
Yeah, we can see the slides. Please continue.
Yeah, should I go ahead?
Yes, please continue.
Yeah. So as I mentioned, most and important is first knowing the clinical criteria. Why is this important? I'll get to the nursing staff later. Right. But knowing the clinical criteria, that being any child more than 35 weeks of gestational age and less than 6 hours of post-birth with any evidence of asphyxia, which may be defined by the presence of any of the two of the following criteria, that being Apgar of less than 5 or 10 minutes, or the baby requiring positive pressure ventilation and chest compression at 5 minutes, a cord pH of less than 7 with a base deficit of 16 or more. If the cord pH is not available, any arterial pH or base excess which is measured within the first 1 hour of birth, along with any evidence of moderate or severe HI. Going on to the next slide. Definition of perinatal asphyxia as per the World Health Organization of the National Neonatal Perinatal Database. It varies. So there is one is being the failure to initiate and sustain breathing, whereas the other one being a moderate perinatal asphyxia, that is slow or gasping breathing with an Apgar score of 4 to 6 at 1 minute, and severe perinatal asphyxia being no breathing or Apgar score at 0 to 3 at 1 minute of age. Whereas the American Academy of Pediatrics and American College of Obstetrics and Gynecology, as I mentioned before, the same previous criteria holds good. Going on to the next slide. Now, why did I mention all these aspects of clinical criteria? Because documentation is most important aspect of treatment and management of a baby with HIE and on therapeutic hypothermia. As we are well aware, and most of the times I am also working in an NABH accredited hospital, documentation is a must, and most of the time the documentation is supremely taken care of by the nursing staff, because they are after us, behind us. Please put a signature, take the consent and take the signature from the patient's relatives, everything. See, these documentation do matter, and it is always important, because we do have to mention the clear documentation of the cord blood gas, or the age of the infant at the onset of cooling, or any specific neurological criteria that has been factored to start the cooling or to defer the therapeutic hypothermia. Going on to the next slide. So, we are well aware that it is not just the clinical skills that is needed for us. It is always the communication, the documentation, as well as communication of the documentation and documentation of the communication and preservation of this documentation. These 5 points are equally important when we are treating and managing, and I can tell definitely 99% of the time this whole onus is borne by the sisters, and we doctors usually tend to miss it off. And they are always taking care that we definitely document these. Now, what happens when the cooling commences? So, as any other babies, you are continuously monitoring and recording hourly the heart rate, respiratory rate, oxygen saturations. Invasive blood pressure monitoring is preferable if you have one, or your NIBP. Surface temperature, most of the times your cooling machine will definitely give the surface temperature using the probe. Core temperature, that is a cooling machine, will display it using the rectal probe. Or if you are using any of the other machine which does not have a servo control, then you will be measuring it using your rectal thermometers. Then the set temperature which you have set on the cooling machine. Monitoring of these is very important. Going on to the next slide. So what can we expect? What happens when the cooling begins? So the heart rate monitoring is most important, because here we are setting the temperature at say around 33.5 degrees centigrade. On an average, the heart rate of the babies which are on cooling will be approximately between 80 to 100. So what happens? This heart rate changes occurs at least around 15 beats per minute for 1 degree centigrade change in temperature. During this process, we will be also monitoring the BP as well as what happens with the hypothermia. The infants are at a risk of hypovolemia also, because the fluid will be going into the third space loss. Hence again there can be heart rate variability. So what kind of heart rate variability that we might be looking for? If there is tachycardia, so that can tell you that the patient may be in hypovolemia, or the baby is having pain or hypotension, that is. So these babies might require going up on an ionotropes, and then following the ionotropes also again you might notice tachycardia. most commonest arrhythmia that we might look for is your sinus bradycardia, which is most common, that following a baby on cooling. Next. When in doubt, always remember to auscultate the baby. Do not forget the stethoscope is most important support for you when in doubt for all these babies on cooling. Next. BP monitoring. Why this is important? Initially, the blood pressure might be on the higher side due to your increased peripheral vasoconstriction. So, in general, within the first 72 hours, if you're looking at for the value of a normal mean arterial pressure, this will be roughly equivalent to your gestational age in weeks. As I mentioned earlier, ideally speaking, we will prefer an invasive blood pressure monitoring, if not your NIBP, if as an invasive monitoring is not available. Central blood pressure can be monitored using your umbilical arterial line or any peripherally inserted cannula is also, radial artery cannulation is fine. Next. Again, when you are using your NIBP monitoring, please see that the cuff used is appropriate. The cuff bladder width should be approximately 50% of the arm circumference. You should see that you are not using the wrong cuff size. Otherwise, you will get a irregular pressure monitoring. Next thing what we monitor commonly is pulse oximeter monitoring. Preferably your right hand, as I mentioned with the arrows, where do you want to fix the probes? On the foot or your head. You can also clip it on your radial artery site also. Most of these disposable ones do come with some sign or star sign or cross sign which is there on these disposable probes. That is supposed to be on the upper side of the baby. So you know that from which side the light is coming and which side is the reader of the probe. The shorter the distance, the better the measurement will be. So never attempt to obtain a pulse oximeter on the limb where which you have already connected a blood pressure cuff. So when it is inflating, you might see that the pulse oximeter readings are coming variable. It might be showing a drop in the pulse oximeter. And again, those bright lights like your bilirubin phototherapy lights or surgical lights can affect again the reading of the pulse oximeter. And do not take the pulse oximeter tightly onto the baby's skin, because remember that it is a pulse oximeter. So the pulsation should be there for the probe to read the saturation. So if you tie it too tightly also, the readings will not come properly. Since the baby is on cooling and there will be peripheral vasoconstriction, always remember to rotate the pulse oximeter side, because we have even seen burns caused by pulse oximeter probes also due to the heat generated by it. Next slide. Next important is your temperature monitoring. See, again, all cooling machine may not be servo controlled, but most of the ones which you are using right now is servo controlled. They have a rectal probe. See that you insert the rectal probe at least 5 centimeters into the anus and take the probe at around the upper thigh so it doesn't come out. It is crucial that the probe remains inserted accurately for the proper servo control. You should keep checking the rectal probe hourly or as per your protocols of your ICU. Shivering is again very common in these infants, and you need to look for that because you should be able to differentiate whether this is shivering or whether it is seizure. Again, monitoring the skin temperature regularly, cross-checking it with your regular thermometer is also important. Next. Rest what we monitor is your respiratory system. Again, if you are starting on cooling, doesn't mean that you need to keep the baby, giving the baby an inhaled oxygen which is not humidified and not heated is not right. The humidification and the heated gas should be given as normal. Those infants which are usually connected to the ventilator who are requiring ventilator support, in that again it should be a heated and humidified gas only. We should always see that ABG is being monitored, so keep a watch for either your hyperoxia or your hypocardia. any of these should be brought to the notice of the treating consultant. Maintaining oxygen saturation is most important. Again, you are avoiding hypocarbia, because if you are seeing that there is a lot of CO2 washout, then again that is detrimental for your CNS. And if there is again CO2 retention, there will be again dilatation, and thereby which can cause you intracranial bleed. So any variation in either of your oxygen or your carbon dioxide levels as noticed by your ABGs should be brought to the notice. Next, fluid management is again most important, as sometimes we will keep the babies on fluid restriction to avoid overload or avoiding a cerebral edema. Most of the times we would prefer to keep the sodium a bit on the higher side, which will help to reduce the cerebral edema. So if any kind of hyponatremia observed, should be again identified and immediately reported. Again, you should remember, due to hypothermia itself only, the water will be displaced into the tissues. So the infants may need additional fluid at times. So we need to watch for any signs of hypovolemia. That is, you're having the hypotension and you're having tachycardia. So they might require again going up on the inotropes to treat the shock due to hypovolemia per se. When we are giving fluids, definitely to give fluids, there will be central line accesses, for which you should have proper catheter care bundles as per your HICC protocols. Your Hospital Infection Control Committee will have a defined protocol. Most of the time we prefer, some ICUs will put your filters to the central lines, which definitely helps. You will have your lower lock system, three-way cannulas or your clave connectors, which has to be strictly cleaned and used as per the guidelines. Next, for any baby on hypothermic and hypothermia, neurological monitoring is most important. Next slide. So neurological monitoring, as this slide shows, this is a modified Sarnath and Sarnath staging. The next one which shows is your living staging. Any of this staging can be used as a scoring in your ICU. So any change in this again should be notified. Easiest way, next slide, being is checking the pupils, evaluating the child's consciousness, whether the child is responding to pain or not, and checking for any signs of raised intracranial pressure, that being your irregular breathing or bradycardia hypertension. So most of these seizures which occurs in the first 48 hours, so you need to watch out for these seizures. So seizure monitoring is again important. Few places there will be continuous EEG monitoring also. Few places we might not have that. So what are the types of seizure that we need to watch out for? Next slide. So most commonest that we see is your subtle seizure, that being your lip smacking, jerking movements of one or either of the limb, arching, facial twitching, eye rolling, cycling of the limbs, excessive hiccuping. So these are the things which you might see. Whenever you're noticing these, please observe the type of seizure, document the duration of the seizure span, and whether if you're having a cerebral function monitoring system, whether it is correlating with that, you need to see. The next slide, please. So you should report and treat these seizures accordingly as per the unit policy or guideline for the seizure management. They might, sometimes babies even might have your subtle seizures that showing your vacant expression, sudden stillness, apnea, desaturation of bradycardia. Again, you should correlate this with your, again, if you have a cerebral function monitoring, which is showing your amplitude integrated EEG. Next. All lab monitorings that come across in this baby are important. Again, different ICUs will have different protocols, but what the nursing care need to watch out for. Coagulopathies are very common with your therapeutic hypothermia, because there will be decreased platelet function as well as the numbers. Preferably, we try to keep the numbers of platelet around 50,000 with an INR of about 2. So any signs of bleeding should be notified, so that either your treatment with your fresh frozen plasma or your platelet transfusion can be taken care of. We, as I said, will be trying to minimize the risk of cerebral edema, so we prefer keeping the sodium levels on the upper limit. So electrolyte monitoring is again important. Magnesium is known to have some neuroprotective effect, and some institutes do use magnesium. So again, the level of magnesium is important. Sugar monitoring is definitely important. Either hypo or hyper, both are detrimental for the neurodevelopmental outcome. So any of these again should be informed. So these are all your electrolytes, creatinine levels, everything should be notified immediately if any variation is seen. Next. Sedation. Sedation for these babies is more of your comfort sedation. That is to see that the babies do not have pain. So different types of scoring system in your ICU might be there, your NIPS or a modified pain assessment tool or whichever pain scoring which you are using. You follow that so as to optimize the comfort and efficacy for the cooling process. So inadequate sedation, what will happen? The baby will be agitated. Again, it increases the metabolic rate. Hence, your cooling will be ineffective. You may consider weaning off your sedation at around 48 hours or so, as when you are planning to near your completion of your cooling process. At times, you might see that increased heart rate, shivering, or if the baby is ventilated, the baby is fighting the ventilator, that will again show us that the sedation is being inadequate. So these things should be immediately notified and plan to increase the sedation should be done. Next slide. Monitoring for the infections. Next. Hypothermia itself can cause your immune dysfunctions. So all these school babies will be on prophylactic antibiotic therapy. Strict infection control practices should be continued as per as your HSCC guidelines, wherein all your catheter sites should be reviewed. Watch for the baby's back or pressure areas wherever there can be pressure source. Going on to the next slide. Pressure source, basically skin monitoring. Next slide. You should frequently inspect the skin and keep repositioning. Next slide. The infants are advisable to be nursed in a supine position. That is what we like to keep the baby's head and the spine in alignment so that the blood flow to the cerebellum is maintained. But at times, due to these pressures and due to the reduced mobility and due to the reduced skin perfusion, you might notice some discoloration at the pressure sites. So you can always tilt the baby to the right or left, at least by around 30 degrees, so that the pressure sites are always keeps changing. Check these areas every 3 to 6 hours. Because one common complication that can occur, though rare, being is a subcutaneous fat necrosis. It is characterized by your erythematous nodules and plaques over your bony prominences. This can cause a hypercalcemia as well as hyperlipidemia and thrombocytopenia again. Going on to the next slide. So, what does it look like? See, this is what it looks like. It will be reddish, purplish color and painful. If it develops hypercalcemia, again we'll be monitoring these babies for hypercalcemia for weeks together and some babies for months. We had babies coming in at even at around 3 months or so with problems of hypercalcemia. Next. Finally, what do we expect when the rewarming occurs? So what all changes we saw with the cooling? A reversal of that. You might see an increase in heart rate, a decrease in blood pressure due to decrease in peripheral vascular resistance. There can be a decreased urine output due to the shunting of the fluid into the third space. And again, electrolyte changes. You might notice hyperkalemia. So you should have a continuous ECG monitoring. Re-emergence of your seizure activity is what you need to watch out for. Do remember that do not turn the radiant warmer on until the temperature of 36.5 is reached. The gist of doing this is, see that you do cluster handling of the babies so that you have to avoid minimal handling so that minimal stimulus is given to the babies. Thank you.
Thank you, Dr. Shriyan, for such a wonderful coverage of a very important topic. Those of you all who are attending here right now, how many of you all have experience taking care of babies with therapeutic hypothermia? Have you done that? Is it being done in your unit? Okay. Those who are online, anybody anybody has any experience of taking nursing care of babies. But if you have not, and in future, if in your units this is started, then this is going to be a good knowledge backup for you of how to do this monitoring and why is it important. Because I think just doing cooling is one part of it, but then ensuring that the nursing care is done adequately is what is going to help us to get the success out of it. So that is important. Thank you, Doctor, for covering this very clearly for them. Any questions? Okay, yeah, so right now there are no questions from them. So in that case, thank you very much. Yeah, so yeah, we'll go ahead with the next talk. Next is on monitoring the vitals and normal values by Dr. Sunil Ganjamat. Is he online?
Yeah.
Okay. Yeah.
Hello.
Yes, we can hear you. And I invite Mrs. Lewis to introduce the speaker.
Hello. Good afternoon, everyone. I'm privileged to introduce Dr. Sunil Ganjamat for this session. Dr. Sunil Ganjamat has done his MBBS from Sri P.M. Patil Medical College, and he has also done his MD along with other degrees, FIPM and PGPN from the Boston School of Medicine, USA. He has an impressive CV and has been faculty for various neonatal workshops and has attended several conferences and posters, and has a lot of publications to his credit also. Currently, he is employed as lead consultant neonatologist at Sahyadri Narayana Hospital at Shivamogga. He has a rich experience of 13 years in pediatric practice, and he has lots of administrative experiences also, and I'm very glad to welcome him to this session on monitoring of vitals in neonates and the normal values. Over to Dr. Sunil.
Thank you. Thank you very much for the introduction. Hello, I'm audible?
Yes, sir, you're audible.
Audible, yeah. I was meeting from Institute P3 Hospitals. The topic for I'm going to speak is on monitoring vitals and normal values in ICU. Okay, the routinely monitored vitals in NICU are temperature, heart rate, respiration and respiratory rate, and oxygen saturation, capillary refill time, blood pressure, and blood sugars. So we can also classify these vital monitoring as one is temperature, then perfusion, respiration and oxygenation and blood sugar. Like that also we can classify. Okay. Hello. Yeah. Coming to temperature, temperature is the foremost important vital parameter which has to be kept in a normal temperature between 36.5 to 37.4. one of the important parameter where we need to concentrate, and where in the few units, if you and it has been linked with many good outcome also. And babies should, especially the high-risk babies like premature babies, low birth weight babies, IUGR babies, and babies with asphyxia, and all, they are very sensitive to sensitive for the heat loss, and they have to be maintained between a temperature of 36.5 to 37.4. Okay, and the baby's thermostatus should be assessed by touch with the diaphragm of the hand. Abdomen should be touched first, then hands and feet should be palpated for the adequacy of temperature. And the NICU, the baby temperature can be recorded by the sensors, warmer sensors probe. And occasionally we also monitor rectal temperature when, especially when during cooling in the core body temperature, which is not affected by the external temperature. Okay, so to understand this, how to maintain temperature, we need to know the physics of some physics also. See, the baby, always the baby should be nurtured in a very thermoneutral environment where the baby will have a baby will be spending less energy to maintain its body temperature. Okay. So usually the babies, usually they lose the body heat by conduction, convection, and radiation and evaporation. So if you know these three things, these physical mechanisms, you can definitely prevent the heat loss. Okay. The next comes the heart rate. The heart rate is the most important clinical indicator to evaluate the clinical status of a newborn. Especially the trends of heart rate will itself will give clue what's happening with the baby, whether baby is improving or it is deteriorating, and it is the foremost important criteria to assess the child vital parameter is the heart rate. So what are the methods to monitor the heart rate? The well-established methods are auscultation and palpation, pulse oximetry, then ECG. And the novel methods are camera photoplethysmography, capacitive sensors, and laser Doppler vibrometer. Okay, so okay, so which are the contact methods? As I mentioned, then again they can be classified as contact methods, intermittent contact, and non-contact methods. So contact methods are the well practice, which are like ECG, pulse oximetry, electrical velociometry, and reflectance photoplethysmography. Then intermittent contact are auscultation and palpation, hand Doppler, and digital stethoscope. The non-contact methods are photoplethysmography camera, capacitive sensor, either photocapacitor or photoelectrodes, and laser Doppler vibrometers. Okay, then auscultation and palpation underestimates compared to ECG. The ECG is the gold standard and best to monitor the heart rate. And the advantage of auscultation and palpation, it is cost effective and easily available. And disadvantages are it is very subjective and intermittent. Only the assessor will be knowing the what are the heart rate and parameters. And pulse oximetry, it is the pulse oximetry is the which is the most commonly practiced in all over the units, in every units. The time required to get the reading can be delayed up to 1 to 2 minutes, but it can be improved the newer signal extraction techniques. It can be immediately also we can within 1 minute also we can get the parameters. But compared to ECG, it underestimates, because ECG, the time taken to record the readings is just only 38 seconds. And ECG leads can be placed more quickly. Okay. Then coming to this non-contact methods like photoplethysmography, these are the novel methods which are not in routine practice and also got a lot of disadvantages. What is the basics is This is the optical measurement technique that can be used to detect blood volume changes in vascular bed of selected skin area. So, camera is placed at a distance of 7.9 inches to 3 feet, and the sensor records the vascular changes, volume changes in the vascular bed. So, what are the advantages of this novel technique? The novel technique, the advantages are improved comfort for the prolonged observation, can be used in dark skin, can be used with high frequency oscillator ventilation, and it will not interfere with other machines like especially like X-rays and phototherapy units. And it is pain free and no impact on parent-child bonding. Okay, what are the limitations of photoplethysmography? The data can be lost due to some motion artifacts and poor illumination. There will be regular interaction between clinical staff and the baby. So these are the limitations of photoplethysmography. ECG. ECG is the gold standard for monitoring heart rate in NICU. What are the limitations of ECG? ECG skin has to be dry for electrodes to be placed, and use of adhesive electrodes could cause stress and can cause erythema on the skin. Limitations of novel methods are which causes part of movement artifacts, where bad sensor coupling, intermittent measurements, and poor quality of recordings. Okay, so what is the normal heart rate for a newborn? So see, the normal heart rate for a newborn ranges from 95 to 160 beats per minute. But when the baby goes for sleep, the heart rate can be as low as 80 during sleep. So you can set an alarm between 80 for the lowest and 160 for the highest, so that we can immediately attend any variation of the heart rate. And an increasing heart rate is an indicator of hemodynamic instability, which should be addressed immediately. Okay, so respiratory rate. So the respiratory rate is the commonly used tool to measure respiratory rate is ECG. ECG is where it can record the chest movements. Or else we can also record by direct visualization, counting for 1 minute. The normal rate of a newborn respiration is 30 to 40 breaths per minute. Anything more than 60 is abnormal. And you should remember that there is something called as periodic breathing. That is, it is very much common in newborns. And there will be episodes of sudden rapid breathing and short pauses of 5 to 10 seconds considered as normal. That is periodic breathing. That is not a sign of any organic disease, pathologic disease. And we should know to differentiate between this periodic breathing and this any organic cause and other diseases in situ, which are causing respiratory distress. Okay, so it is as an newborn nurses, we need to know the pattern of respiration rather than just looking at the respiratory rate. Okay, so one entity which is the periodic breathing is a normal entity in the newborns. Whereas if you see any intercostal retractions, sternal retractions, flaring of the melanizing, tachypnea and grunt, and if you see the increased work of breathing, these are all indicative of some underlying distal airway disease, which is like alveolus lung. Hello, am I audible? Hello.
Yes, sir, you are audible.
And so okay, if the retractions are suprasternal, subcostal, then it indication of upper airway diseases. Upper airway. And if there is a tachypnea without effort, if the infant is quiet, but there is only tachypnea without much of effort, But baby is not somnolent, then it suggests you have cardiac issues. If the baby's efforts are very shallow, like poor efforts, comparison with the physiologic need, intermittent apneas, they are indicative of neurodepression. Then, if there is a tachypnea, apnea, and baby is lethargic, very minimal retractions, then it is indicative of metabolic acidosis of sepsis. Okay. Then come to oxygen saturations. With oxygen saturations, the normal values will be at 10 babies, at 22 after birth, the normal babies, 10 babies it will be more than 90%. But immediately after birth, don't expect baby to have a 90%, more than 90% of oxygen. It takes at least 10 minutes after the birth to reach the normal values. Okay, more than 90% oxygen saturation. So, what are the how we can monitor the oxygen saturation? We can monitor the oxygen saturation by either invasive or non-invasive methods. The invasive methods are like puncturing an artery and getting an arterial blood gas analysis, but it is very invasive. We can't do it in all babies. Whereas non-invasive methods are the pulse oximetry, which is widely used, and pulmonary graphics with the babies and babies connected to a ventilator. And before 1980s, where the pulse oximetry was not commonly available everywhere, there was transcutaneous partial pressure of oxygen, pressures of oxygen was also monitored. Okay. So pulse oximetry, it's a primary and it is a non-invasive tool. Monitoring in oxygen saturations. So it's continuous monitoring of oxyhemoglobin with high level of accuracy, at least like plus or minus 3%. The principle behind pulse oximetry is it is a spectrophotometry, differential light absorption of oxyhemoglobin and deoxyhemoglobin blood for two different wavelengths like 660 and 940 is assessed by the sensors. The proportion of absorptions of light at these wavelengths is calculated to establish, and the sensor establishes the saturation. The pulse oximetry may get affected by movement artifacts, ambient light, pigmentation, and low perfusion states. These are the limitations of pulse oximetry. Even the phototherapy units can also affect the pulse oximetry readings. What are the disadvantages? The pulse oximetry will not measure the partial pressure of oxygen, arterial partial pressure. There is insensitivity in detecting the hyperoxemia. Due to shape of the oxyhemoglobin curve, with the SpO2 is 95% and PaO2 may be more than 100, 180 or something like that, but it is it is insensitive to detect partial pressure of oxygen. So low amplitude pulse wave in preterm may introduce artifacts or episodes of desaturations. Then other artifacts with the disadvantages are inappropriate sensor placement, presence of high intensity light can also interfere, and the fetal hemoglobin, if it is more than 50%, that can also interfere, and presence of other hemoglobins like carboxyhemoglobin and methemoglobin can also interfere with the accurate measurement of the saturations. So perfusion can be assessed by measuring the blood pressure and capillary refill time and color also. So perfusion can be assessed by all these three tools. Okay. BP, if you practically speaking, blood pressure is not routinely assessed in routine newborn care. It is only assessed when it is required, especially when the baby is requiring the babies which are in shock, requiring invasive hemodynamic monitoring, and requiring inotropic support. In those cases, the blood pressure is monitored routinely. So, as been already previously discussed, the proper neonatal cuff should be used, and the extremity used should be documented before. It should be documented. Okay. So, what are the normal values? The normal values are systolic. Anything less than 60 is hypotensive, and diastolic less than 48 is repeat as hypotensive. So in preterm babies, the mean arterial pressure should be recorded, and any mean arterial pressure which is less than the gestational gradient of more less than the gestation is considered as a baby's hypotensive. A gradient of more than 10 mm of Hg between upper and lower extremity should be a suspicion for a coarctation of aorta. Okay, coming to a very easily most commonly practiced assessment, perfusion assessment tool is capillary refill time. The capillary refill time is defined as the time required for return of normal color after application of blanching pressure to a distal capillary bed. Okay, so capillary refill time will be measured by pressing an index finger over the mid sternum of baby for 5 seconds, and complete return of skin color after removal of the finger was taken as a capillary refill time. The value of CRT is not fixed in all the ages, so it also varies depending on gestational age, ambient or skin temperature, and site of measurement, and duration as well as amount of blanching pressure and inter-observed variation. So that lot of variations are there. So we have to be checked properly as described. So CRT is being affected by necessary equipment like warmer, also phototherapies. So we should switch off the phototherapy by measuring the capillary refill time. The normal value of capillary refill time in healthy neonate is plus 2 to 3 seconds, but it never passes more than 3 seconds. The major determinant of capillary refill time in healthy neonate are birth weight, radiant pharma, and phototherapy units. The capillary refill time alone in neonatal age is less informative. Hemodynamic parameter. It should be evaluated along with either blood pressure, oxygen saturation, with pulse meter, and even the heart rate. So it is not contribute as a single parameter for a decision making. It's just contributed to assessing a perfusion. So blood sugars. The plasma glucose is for monitoring the blood sugars, the most commonly used methods are the bedside glucometers will be used, but the gold standard is we have to use the plasma glucose. That is the gold standard. But most commonly what we use in bedside is the whole blood glucose. Usually it will be 15% less than the plasma levels. So bedside glucometers is used. These are the major tools to use monitoring the blood sugars. So what are the target blood sugars bedside monitoring? So usually initially for devices is up to 45 mg per dl is considered as normal. That corresponds to 50 mg per dl of plasma glucose. First, after 42 to 72 hours, the normal value should be 50 mg per dl. Okay. So that finishes my talk regarding the vital monitoring in ICU. Thank you.
Hello. Thank you, Dr. Sunil, for a very informative session on monitoring of vital signs. You have touched upon all the important vitals such as the temperature, the pulse and heart rate, and the blood pressure monitoring, and instead of blood pressure what we can monitor like the CRT and the color of the baby. Along with that, you have also touched upon the pulse oximetry, which is very important. So monitoring of vitals is very important nursing responsibility in the NICU, and most often nurses are the ones who monitor these vital signs. Along with the basic information, you have also told us about other things, advanced parameters, advanced techniques which can be used to monitor these parameters. So with that, I open the floor for any questions or comments from
from the participants? Do you have any questions? No? So the participants are not having any queries at this moment. So, yes, any queries from the participants who are attending virtually? You can unmute and ask. So I don't think there are any questions. So I thank Dr. Sunil once again for the session. And yes, let's move on to the next session.
Next we have Mrs. Jessie Shaji Paul, who is a graduate nursing from College of Nursing AIMS and postgraduate from RAK College of Nursing, New Delhi. And she has a various degrees like Diploma and NNF Certified National Trainer for NRP. And she is certified for Quality Improvement Training by IHI USA. Now she is currently in Service Educator. Ma'am, I'll welcome you.
Thank you for the introduction. Since morning we are hearing about the parameters and the monitorings. So like the neonatology has improved a lot and the technological management has also increased a lot. So care of a baby on ventilator is a paramount important as we nurses. So our next speaker is, I am very privileged to introduce the next speaker for the day, Ms. Gitanjali Kalyan. She is currently working as a tutor at National Institute of Nursing Education, PGI Chandigarh, and she is currently as a PhD scholar and member of IANN, that is Indian Association of Neonatal Nurses, and she is a EB member of National Neonatology Forum also, and other associations as displayed over here. And she is has total of 14 years of teaching experience on different positions in 3 universities, and her field of interest is family integration, neonatal nursing and child health nursing. And she has a lot of publications to her credit and has been a resource person for more than 45 national and international conferences at work. And over to you, Gitanjali, for the topic on care of ventilator babies.
Thank you, ma'am. So now we are going to talk about a very important and practical aspect of the newborn care. And I just want to, before I start the session, I just want to know how many of you are posted in NICU. All of you are NICU nurses? All of you are NICU nurses? Or any of you are students also? No students, all nurses? Okay, you are posted in a government setup or in a private setup? Private, how many bedded hospital you have? I mean NICU. NICU is 5 bedded. Okay, so you see all type of patients who are on CPAP and ventilator both? Okay, CPAP mainly? CPAP mainly you are seeing, not the ventilator one. Okay. Okay, so we will be talking about both the aspects, the babies who are on non-invasive ventilation and those babies who are on invasive ventilation, both. Okay, next slide, please. Okay, thank you. Okay, so this is my workplace. I work in this institute. This is National Institute of Nursing Education. We teach graduate and postgraduate students, and we also run a PhD program at our institute. And this is our temple of learning. This is Advanced Pediatric Center, where we escort our students to learn child health and neonatal nursing. Okay. Okay, so at the end of the session, I hope that you will be able to identify the need of respiratory support among neonates who all other candidates would be requiring, identify types of respiratory support, provide effective and efficient nursing care to neonates ventilated by invasive or non-invasive ventilation, and ensure holistic care. Many aspects we have covered since morning, like management of pain and other things. They are also part of holistic care, so we would be discussing those which are left, right? So, types of respiratory support, there are two types, right? One is non-invasive, another one is invasive. In non-invasive, we do not use any artificial airway. It's not being inserted inside. And this is used for the babies who are having poor respiratory efforts. They have efforts, but they have poor respiratory efforts, right? And they are not spontaneously, either they are not spontaneously breathing. They're trying, but they need some support. So support deke, unke lungs mein we put some pressure, like we blow a balloon, right? We put a pressure. Till the time the pressure is there, the balloon is open up. So that's the purpose. And in addition to this, like CPAP is one of the non-invasive mode. There are other modes also that can be delivered with the help of non-invasive device. They work similar as other modes which we deliver with the help of non-invasive ventilation. Invasive ventilation. But the mode is non-invasive. No ET is being inserted. So, invasive ventilation, use of artificial airway is done when we fail to maintain on NIV. So there is a failure criteria, and we nurses have a role to identify when the baby is not maintaining on non-invasive ventilation. So that is one. So once we have identified that, we will discuss with our physician and we will plan to shift the baby onto invasive mode of ventilation, and we set up all the things, right? And the babies who are having respiratory failure, they are the candidates who directly go on to the invasive ventilation. So who all are those babies? Those who are having neurological problems, apnea, asphyxia, IVH, the babies who are having lung pathology, HMD, CDH, and pneumonia. So these are the babies, they directly, if they have respiratory failure, they meet the criteria of respiratory failure, they directly go to invasive ventilation, right? So why preterm are greater risk of needing respiratory support as compared to term babies? Why? Because there is a lack of adequate lung development and surfactant, right? In which babies it is more or less the babies who are born before 32 weeks of gestation. Okay? So in them the surfactant is much lesser, and to improve their outcome we also administer a drug in antenatal period. What's that drug? Betamethasone or dexamethasone, right? So that help in maturation of the lungs, that help in formation of that surfactant inside the baby's lung. So preferably it should be given before 24 to 48 hours of birth, and we should try that we could stop the progress of labor for that particular period of time at least. So further it is complicated by apnea. The baby's brain is not that well developed, so babies are more likely to have apnea. They are unable to maintain the high work of breathing. So that's why these babies are more likely to get ventilation after their birth as compared to term babies. So there are some number of things that are more traumatic when the baby is on invasive ventilation. So ventilator-induced lung injury is very common, and these are the four main pointer. कहाँ से आएगा? Red pointer. नहीं आएगा? Okay. So there are four main injuries. First one is volute trauma. Because of high volume is being delivered, the alveoli they get ruptured. ज़्यादा volume दिया. Then barotrauma, the pressure. Atelectotrauma, the injury around the alveoli, and then biotrauma. All the debris they get accumulated and cause the injuries, right? Then other complications are also associated with invasive ventilation, like bronchopulmonary dysplasia, which is very common, and the babies have to stay on oxygen for a longer duration, maybe for 2 months or sometimes for 3 months. And then airway injury, increased risk of infection, because we are directly into the airway. So we have to provide a meticulous care to these babies to prevent them acquiring the infection, so that they do not have hospital-acquired pneumonias, they do not get sepsis, they do not land up into shock. So we have to be very, very careful while dealing with their airway, right? Then air leaks can be there and decreased cardiac output. So we have to monitor the babies very critically so that we manage them well when they are on invasive ventilation, right? So these are the other problems that can happen. We have learnt in the morning about DOPE, right? Dislodgement, obstruction, malposition and other things. These can happen when the baby is intubated, right? So these all are the problems that can occur. So these are the modes of ventilation. I hope all of you are aware of synchronized, non-synchronized mode of ventilation, SIMV, SIPPV, PSV, IMV and IPPV. So these all are the modes of ventilation. Non-invasive में जब डाला है, और अगर बेबी को आपने इन्वेसिव में डाला है, अगर आपने नॉन इन्वेसिव में डाला है तो इन सब के आगे क्या लग जाएगा, N. So all modes can be delivered with the help of non-invasive ventilation also, with your rams and with your prong. वो non-invasive के साथ भी ये सारा modes हम दे सकते हैं, ठीक है? So now I was talking about CPAP failure criteria. Like you have put baby on CPAP. पहले थोड़ा रेस्पिरेटरी एफर्ट कम था, CPAP पे डाल दिया. अभी CPAP का फेलियर क्राइटेरिया पता होना ज़रूरी है. Until unless we know it, we won't be able to shift the baby to invasive one, है ना? Early identification नहीं कर पाएंगे, baby deteriorate करता रहेगा. So this is the criteria. There is the increased work of breathing. CPAP usage is more than 7 centimeter of water. 7 से ज़्यादा हो गया है. FiO2 is 80%, है ना? ABG, PO2 is less than 50 and FiO2 is increasing. 60 से above 80 use हो रहा है आपका FiO2. PCO2 is more than 60 or more than 55 if the pH is less than 7.2, right? So this is, and the baby is showing recurrent apneas also. आपको देखने में लगेगा कि baby को बार-बार apnea हो रहा है. So you have to check on all these parameters, and if this is happening to your baby, you have to plan to shift your baby to the invasive mode of ventilation, right? So this is the, you have to ensure before you declare that the CPAP is a failure, you saw these things, you have to ensure these things were in place. Say for example, ensure before declaring CPAP failure that interface is correctly fitted, your prong, your mask is fitted properly. Fit नहीं होगा तो obviously failure देगा, है ना? Then equipment working properly, is it working well or not? Water level adequate है कि नहीं? Bubbling हो रही है कि नहीं हो रही है? Oxygen source is connected or not connected? Adequate supply, कितना liters per minute पे चल रहा है? No obstruction to the flow of gases, it's freely flowing, right? Airway is clear and baby is not fighting. So if all this is sure and still the baby is showing the sign of failure, shift the baby to invasive mode of ventilation. Right. So this is again the failure criteria being reflected for the revision purpose. So now shift the baby to invasive ventilation. So role of nurse comes in receiving the baby and monitoring the baby, right? So receiving baby, you have to prepare the team for receiving the baby. You have to set up the ventilator, setting the multi-channel monitors and the radiant warmer before the arrival of the baby. And if you talk about the holistic nursing care, list difference in care of NIV versus invasive, there is little difference. There is a little difference between the care, but otherwise overall holistic care of the baby remains the same. कुछ components हैं जहाँ पे थोड़ा difference है, like अगर in non-invasive ventilation पे you have to take care of the nose part of the babies more, you have to take care of abdominal distension and other aspects, right? But if the baby is on invasive ventilation, the things are little different, but overall care, overall components of the care remains the same. So what are those components? First one is monitoring baby receiving respiratory support. So you have to monitor the baby critically and meticulously. Provide comfort to the baby. Infection control, we follow all ANTT practices. I will in slides show you what is ANTT and how to use it. Feeding and thermoregulation, that you are doing already in day-to-day basis. Then developmental care, like atraumatic care, skin care, it includes there's a mistake in spelling, I'm sorry. Atraumatic care, skin care and other things. So we have already learnt about atraumatic care in the morning session, so I'll not talk about that in detail. Physiotherapy and family integrated care. So these are the components of holistic care. So now setting the team, doctor, experienced nurse and technician should be there in your team. Antenatal and prenatal history to be taken. I was referring to antenatal steroid, whether mother has received or not, because that will help you know कि lung थोड़ा mature हो गया होगा कि नहीं हो गया होगा, right? Then maternal illness, premature rupture of membrane, because these parameters help you to decide कि कितना baby आपके पास जो आएगा, how sick the baby is going to be, right? Then maternal drugs, if mother has taken some opioids, definitely the baby will have respiratory distress. Asphyxia. So anticipating the problem is very important. That help you to make wise decision when the baby comes to you with the problems, right? Then multi-channel monitor, keep it ready, switch it on beforehand, check it is working, functioning, set the monitor, higher and low pressure sets, all the alarms have to be set. How much pressure, how much alarm you set for the oxygen saturation for your babies in your unit? Saturation. 95. Upper and lower limit. We set a lower limit and we set a upper. 88 to 93. So that's the range. उतने से कम होगा तो अलार्म बजेगा, उससे ज़्यादा होगा तो अलार्म बजेगा, and then you have to address the baby, right? So it is important to set the alarm limits beforehand so that you respond to the baby correctly and on time when it is required, right? Then respiratory rate, heart rate, invasive, non-invasive blood pressure, all the values have been shown to you in the monitoring session कि कितना normal values हमने रखना है, so I'm not talking about that. You have to set these things on the monitor before you receive the baby. Okay, then you have to keep the resuscitation equipments ready. That may be required because we have to ventilate the baby, we have to intubate the baby. So all these equipments should be there with you. So I'm not reading the list, but you have to keep it ready. You can click a photograph if you wish to. Then the endotracheal suction catheter sizes and ET and how much length to insert. So there are two things you need to remember. For babies who are more than 1000 gram or the babies who are term, this formula is being used. And for the babies who are preterm, we use nasotargus length. I have shared in the group this nasotargus length, कितना आपने कैसे measure करना है from tip of the nose to the targus, and then for different age groups, how much length to insert. I have shared in the group, you can review from there. So this is the formula you have learnt in the morning also, in the first session, so I am not repeating it. Shall I skip? Yeah, you have already learnt it. Okay, so on radiant warmer, we have to prepare the bed, put on manual mode, switch it on half an hour prior, set the heater output to 100% in the beginning, and keep the bed ready. You have to make a nest. All of you must be making the nest for the babies to keep them. And then you have to ensure that you have also kept a shoulder pad on the bed itself. And once the baby has come, quickly record the weight, place the baby on the bed and connect to the respiratory support. Attach the temperature probe, keep it at servo mode, switch off the manual mode of heater, 100% बंद कर देना है अभी, servo mode पे डालना है, and set the temperature limits as we discussed for the oxygen also. These are for the temperature 36.5 to 37.5. Attach oxygen saturation probe and monitor and record the vitals, right? So ensure the monitoring. In the monitoring, learn these things, that is invasive blood norms. Mean BP is nearly equal to gestational age of babies in weeks, right? And target saturation I have already discussed, 88 to 93, that is the target saturation you would be setting. ET size and length of fixation I have already shared and you have already seen in the previous session also. Then size of the suction catheter. What is the size of the suction catheter? You have learnt in the morning. No, we will not follow 8 for everybody. It's double the size of ET. Double the size of ET. ET का size आप weight से निकाल लेते हो ना, 1000, 2000 to 3000, 3000 to 4000 for, because ET का size आ गया. Say for example you are using ET of 3. So what will be the size of suction catheter? 6. If it is 4, then 8. 8 is not universal to all. Say for example you have very preterm babies and you are using ET of 2 size, तो उसमें तो 8 जाएगा नहीं ना. So you have to use the smaller one which has a smaller diameter, right? No. So monitoring may, it's not only monitoring the baby, the other things are to be monitored also. है ना? Let us see what other. You have to monitor the baby, that is the prime. वो clinical देखना है. Interface को देखना है, prong, nasal prong और endotracheal tube को भी देखना है. Displace तो नहीं हो गई tube अपने place से. अगर आपने मास्क यूज़ कर रहे हैं या prong यूज़ कर रहे हैं, वो displace तो नहीं हो गए. Are they properly fit? Are they in the center? Right? Then machine, you have to look the circuit. Circuit is working functional. कोई कंडेंसेशन तो नहीं है, लीक्स तो नहीं है उसमें. FiO2 you have to check. Humidification of the chamber is very very important, है ना? How much temperature do we set for the humidification? Yes? 100. वो ह्यूमिडिफाई करने के लिए रहता है ना, वो थर्मिस्टर लगाते हैं जिसमें हम उसमें टेम्परेचर आता रहता है. नॉर्मल बॉडी टेम्परेचर 37 पे हम सेट करते हैं ना, वो जो थर्मिस्टर लगा रहता है गोल वाला ह्यूमिडिफायर का, ठीक है, तो उसका टेम्परेचर आपको इंश्योर करना है. And then you have to also look for the complications. So this is the clinical monitoring you have already learned in the morning. Still it is important to repeat because our topic is monitoring of the baby. So first thing is the vital signs. You would be monitoring the vital sign, respiratory rate, heart rate and blood pressure. You will look for severity of RDS. Are you aware of how to look for severity of RDS? RDS का severity कैसे देखते हैं? कुछ tools होता है. Yes, you are saying something? We will be discussing the tools. Silverman and Downs score सुना है? Have you heard it? हाँ, those are the scores that help us to identify how severe, what is the severity of RDS. Then perfusion, you have to look for CFT. How to check CFT in a newborn baby? Capillary filling time कैसे check करते हो? Adult में तो यहाँ से करते हो. So newborn में कैसे करते हो? How do you do it? CFT. करते हैं ना? करते हो कि नहीं? No? Okay. So how to do it? You have to look at the chest of the baby and slightly press over the sternum gently. ठीक है? You have to count. You have to keep looking at the, say for example, this is the sternum of the baby. So you have pressed it here. You will count 1001, 1002, 1003, 1004, 1005, and then you will release. Keep counting 1001, 1002, 1003. Say for example 1002 बोलने से पहले it become pinkish. जब आपने प्रेस किया था तो ब्लेंच हो गया था, येलो हो गया था. अब आपने रिलीज किया तो वापस से रेड हो जाएगा. So CFT would be less than 2. अगर 3 पे गया, 4 पे गया, पिंक हुआ तो that would be your time. So more is the time, that means circulation is poor. उतना circulation poor है, either the baby is in the shock, baby is in hypovolemia, है ना? So it is important to monitor CFT. So it should be a practice, a routine to assess CFT on daily basis. आपके monitoring chart में there must be a columns. Is there any column for CFT? You should add a column. Then BP, peripheral pulses, central pulses, urine output. Urine output कितना normal रहना है baby का? Normal output, hourly base पे हम देखते हैं ना? How much? जैसे अब असेस करना है ना कितना यूरिन आया है, वे करते होंगे, डाइपर्स को वे करते होंगे आप, एंड देन काउंट करते होंगे. 1 to 5 ml per kg per hour, उससे कम नहीं होना है, राइट? 1 से कम तो बिल्कुल ही नहीं होना. 1 to 5 ml per kg per hour. So that should be the urine output. You have to look for cyanosis and the color of the baby. You have to monitor the abdominal girth. Why it is important to monitor the abdominal girth? There may be any distension, feed intolerance. So all those signs can be captured earlier, right? So do you monitor abdominal girth in routine for all the babies, or for the babies who you feel like they are abdominal distended? You should do it in pre-OSS. When you are receiving the baby onto the bed of the baby, we have a routine to put a measuring tape under the baby and measure the abdominal girth once we receive the baby. So that's your baseline. So उस baseline को आपने record कर लेना है अपने monitoring chart में, and then every time when we are giving the feed, before giving the feed, you check abdominal girth. If it is more than 2 centimeters. Okay. So you can So you can check the abdominal girth before every feed. If it is more than 2 centimeter, that's an indication that the baby is having abdominal distension. You have to aspirate and you have to inform the physician, maybe we need to withhold the feed. Right? So that's the importance of it. Then you have to look for the bowel sounds also, and this is one important thing, gastric aspirate to prevent CPAP belly. So this is an important nursing intervention when your baby is on invasive, non-invasive ventilation. You have to put the tube inside the stomach and keep it open so that the belly is not distended. Okay, that will create discomfort for the baby, breathing difficulty, improvement नहीं होगी baby के status में. So that is important. And then you have to look for neurological status. You have to look for tone, activity and responsiveness of the baby. And then in electronic monitoring, again you have to look for the electronic monitoring, respiratory rate, heart rate, SpO2. This is not 87, this is 88 to 93. Then look for PEEP if the baby is on CPAP and if the baby is on invasive ventilation. Invasive ventilation पे होगा तो PEEP थोड़ा ज़्यादा हो सकता है. And this is between range is 4 to 8. And then you have to look for PIP, FiO2, MAP, temperature humidifier, and time of inspiration and time of expiration. So other investigations like ABG and chest X-ray is also being done on routine basis. So this is the monitoring of the baby when your baby is okay. So this is the Downey score I was referring to. This is mainly used for the babies who are term. So Downey score for respiratory rate, and these are the parameters: respiratory rate, cyanosis, retraction, grunting and air entry, and you score them 0, 1 and 2. है ना? Air, so and after scoring them we do the total for the scores. Okay, and this is the another score that is Silverman-Anderson score. This is used for the preterm babies. So this is also having grades 0, 1 and 2, and this is the parameters: upper chest, lower chest, xiphoid, nasal dilation and expiratory grunt. So you would be looking at these parameters and then you would score them and then total. If the score is more than 6, and it is indicative of impending respiratory failure. So you have to total the score. I hope you have used these scores in your setup. Are you using them? No? So what you can do is, you have clicked the photograph, note down their names. You can paste them on a piece of paper. You can start attaching it in your nursing assessment sheets, and you can start learning with your physicians. वो तो daily करते ही हैं. तो जब उन्होंने किया ना, उसके बाद आप भी एक बार करके देखो, so that उनका और आपका score match किया है नहीं किया है, and then learn from them. They will help you out कि उसको कैसे करना है. So then you will become more accurate in your assessment. Comfort and position to optimize gas exchange. To improve oxygenation, you should use supine position with slight neck sniffing, right? Prone when feasible, as this improve oxygenation and help in better tolerance of feed and promote better sleep and pattern. To prevent aspiration, use semi-prone or the sideline position. To prevent decrease in lung capacity, to prevent decrease of lung capacity and increase intracranial pressure, avoid Trendelenburg position. You are not supposed to give Trendelenburg position. And after the feed, what is the position you give to your preemies or your term babies after the feed? Feed के बाद position देना is very very important, you know. Sideline में कौन सा left या right? उसमें भी कुछ difference है or is it same for all? Left side for term and preterm both? Okay, so remember, left lateral position for the preterm babies, okay? And right lateral position is for the term babies, because that help in gastric emptying in the term babies. However, in case of preterm babies, the right lateral is not being advocated because they also have gastroesophageal reflux. तो अगर उसको राइट में डालेंगे प्रीटर्म बेबी को आफ्टर फीड, तो उसको GER ज़्यादा होगा, तो उसको लेफ्ट में डालना है फीड के बाद. और टर्म बेबीज़ को GER नहीं है बिकॉज, तो इसलिए उनको हम राइट में डाल सकते हैं. दैट फैसिलिटेट गैस्ट्रिक एम्प्टिंग. इज दैट क्लियर? राइट? Okay, so this is the medication administration protocol. I was referring to A and TT because you have to protect your baby from infection also, right? So this is A and TT. Let us learn. This is very important. We have to handle all peripheral and central lines with strict asepsis, and all the lines, the suction catheters and other things with strict asepsis. It includes aseptic non-touch technique. This was introduced by Rowley and Claire S. This is very, very famous technique now. So use this practice in day to day. It includes standardizing invasive procedures. So अपने यूनिट में जो भी procedures आप invasive procedures कर रहे हैं उनका एक protocol बना लीजिए. Have a written booklet. Discuss with your in charge of the unit. Sir, we want to have a written booklet for invasive procedures in our unit. कैसे करना है, क्या setup करना है, everything. Then management of aseptic field. You manage your aseptic field. Create a sterile area. If you more likely in all NICUs, mainly sterile trays must be coming. Do you get sterile trays to prepare the drugs or not? Or you prepare in laminar flow, or how do you prepare? Huh? You get sterile trays. In any case, you're working in a setup, आपको sterile tray नहीं है तो उसका कोई way है to create a sterile field? Not be without it. You clean it with 70% alcohol or 2% chlorohexidine for at least 3 to 5 minutes, and that become your mobile sterile field, and then you can use it. But make sure that you keep things by protecting their key parts. अगर syringes उसमें डालना है तो डायरेक्ट नहीं डालना है ना, उसमें नीडल लगा के डालना है अटैच करके, so that they are protected. So you have to protect the key parts and key sites. Key parts, non-contaminated equipments, those are to be scrubbed with 70% alcohol or 2% chlorohexidine. So key part, अगर आप cannula का key part की बात कर रहे हो, so cannula, if you want to give the medication administration, you have to clean the cannula with a spirit swab from outside. 70% alcohol. उसको पहले बाहर से clean कर दिया, open it up, attach with a needle, so that it's not contaminated. You are not keeping it here and there. हाथ में नहीं पकड़ना है, and then close it, and then clean the inner part of the cannula with a squeezed spirit swab, so that by accident you do not spill spirit inside the cannula, right? So key sites, sterile body parts must not come in contact with the non-sterile items. So these are the main components of ANTT. You can read and download these practices in detail from internet and learn about them. It's not moving actually. Okay, so now respiratory monitoring, chest movements, chest rise, synchrony with the ventilator and breath. It is important to see there is a synchrony between the monitor, the ventilator delivering the breath and the baby taking the breath. So it is important to see, you have to look for the retractions if the baby is having respiratory rate and air entry. And if there are any issues with it, you need to inform your physician. Check for adequacy of ventilation. You have to look for tube position, tube fixation, ventilator and connections, humidification, and monitored use of oxygen. Right? We have already discussed this. This is just a summary of that. So now the babies with CPAP and non-invasive ventilation, we will be discussing about their care also. So mainly in them, some complications they can occur. First one is nasal trauma and bleeding. Right? Air leaks can be there. Then tube blockage. If a tube blockage is there, then would be a problem. And especially you have to look for the prongs also. Are they open? Prongs are also open where you are putting Ram's cannula or any other. और उसमें secretions की वजह से कई बार blockage हो जाएगा, तो आपके baby को adequate CPAP deliver नहीं होगा, वो देखना है. Then look for the feed intolerance and stomach distension, intracranial hemorrhage, PDA, and failure of CPAP. So these are the things which you need to monitor if your baby is on non-invasive ventilation. So this is the pictorial chart we have developed. This is developed by one of my student. She is doing masters under me. So this pictorial diagram is showing all the hypoxemia, bradycardia, atelectasis, mucosal trauma, infection, and pneumothorax. Then length and pressures. अब कितना length अंदर insert करना है suction catheter is very very important and meticulous. And in our setups, like we have students also coming to our ICUs, MSc students coming, 4th years coming. So it is always wise to measure the length and put it on the chart with the red color. This much length to insert, not more than this. So how to measure? 6 plus infant's weight plus tube outside, जितना भी tube का length outside है, connector तक हम measure कर लेंगे. And then we will label this on our chart that this much is to be inserted. Is that clear? तो कितना वहाँ टिप तक तो हमें पता होगा, दिख जाएगा कितना है इंसर्टेड. Usually it is 3 times the size of ET if a rough estimate we take. So say for example you have put a ET of 3, तो 3 इधर 9 पे नियरली फिक्स होगा. उसके आगे जितना लेंथ है वो मेजर कर लीजिए, कनेक्टर का लेंथ मेजर कर लीजिए एंड राइट इट ऑन द चार्ट. Right, keep suction pressures between 60 to 80 mm of Hg for preterms and 80 to 100 for the term. FiO2 prior to suctioning only increments of 2.5%. Usually there is a routine, suction करने लगे तो पूरा 100% पे डाल देते हैं ना हम लोग. We put it on exact 100% कर देते हैं. Do we do it? जब suction करते हैं तो 100% करते हैं. FiO2 नहीं करते, नहीं करना है. It's not a routine. So increments में करना है 2 to 5% and do not do it to 100% because it can cause retinopathy of prematurity. If secretions are thick, disconnect the ventilator and instill normal saline. You should not use distilled water. Only normal saline to be instilled 1 or 2 drops and then do the suction. Then chest physiotherapy is the another important component of the babies who are on ventilator on this thing. One of the most important aspect, suction, position and percussion. So routine physiotherapy is avoided in babies who are less than 1000 grams. The babies who are less than 32 weeks in first 3 days. Air leak syndrome, the baby is having air leak syndrome. The baby is having persistent pulmonary hypertension. Baby is having intraventricular hemorrhage. And remember, CP chest physiotherapy is not required in first 48 hours of admission usually because there are no consolidations, nothing. So it's not required, not to be done in a routine basis. Okay, then problems and benefits while giving CP physiotherapy. What problems can occur? Hypoxia and hypercarbia can occur. Decreased chest wall movement, increased blood pressure, bradycardia, increased respiratory distress, decreased air entry, intracranial hemorrhage. So these can be the problems that can occur. और benefit क्या है? It remove the secretions and improve ventilation, oxygenation and clear the atelectasis. But benefits के साथ problems भी बहुत सारे हैं. तो इसलिए unnecessarily भी नहीं करना है, right? When it is required, it is to be done. Similarly as for the suction. ठीक है? Ventilation for more than 72 hours for pneumonia or MAS. Always change the position 2 to 4 hourly. Suction 2 to 4 hourly, but here also you have to assess the need for suction and then percussion for 4 hourly, right? So this is a rough guideline that can be used. Then lung collapse, position 2 hourly, suction 2 hourly and percussion 2 hourly. But still again you have to assess. If it is required, do 2 hourly. If it is not required, don't do it. Right? Complications associated with suctioning include hypoxemia, bradycardia, atelectasis, mucosal trauma, infection, increased blood pressure and pneumothorax. So sudden deterioration in ventilator, this has already been discussed. Ventilator malfunction, ET problem, air leaks. Take the baby on bag and mask ventilation. Increase FiO2 to 100 and check for the vitals, air leaks and chest rise. If there are absent sounds, no chest rise, abdominal distension, must be ET tube displacement, right? So you have to work on that. And reduced breath sounds and chest rise, gurgling sounds are there, then there must be ET secretions. So there's a need of suctioning. So this is to be evaluated and appropriate action to be taken. Developmental care has already been explained in the morning session by Dr. Kiran, so I'm not going to talk about in detail. This is all environment modulations, developmental care, light position, everything you have learned in the morning. So this is day and light scenario we create in our setup. We switch off the lights and then or either we cover the incubators with the blankets so that the babies do not get exposure to intense lights. These are the non-pharmacological measures. This is the first one is swaddling and the second one is facilitated tucking. Facilitated tucking is as easy. अगर आप heel prick करवा रहे हो, कैनुला डलवा रहे हो, तो बेबी के दोनों हैंड्स को ऐसे होल्ड कर लो and hold the legs fold करके and then get it done. And you can involve the mothers also if you feel the mother is confident, उसको कोई fainting नहीं हो जाएगी, बैठ के कर सकती है. So you can involve the mother also in facilitated tucking if you have lesser time. कि physician के साथ कितनी देर खड़े रह के नहीं कर सकते हैं, right? Like these are the all measures you have learned in the morning. So I'm skipping this. Then pharmacological measures you have already learned in pain management. I'm skipping this. It has been added because it's a part of holistic care. Skin care. Nobody has talked about skin care, so I'll touch on this. Skin care of neonates born before 28 weeks of gestation is like an open wound, right? So care should be given like an open wound. Sterile care should be given. So do not involve your mothers in the first 2 to 3 weeks of giving skin care. Preferably it should be given by the nurses. So preferably it should be given by the nurses only. And use sterile water and sterile packs. आप कौन सा water use करते हो babies को sponge करने के लिए अपने unit में? Sterile water? कहाँ से लेते हो sterile water? Normal water you use. Okay. You should preferably boil the water for the babies. Puneet? So you should boil the water for the babies, especially who are born before 28 weeks of gestation. You should not use. In our setup, we have RO water system and the boilers attached, so we use that water, right? So application of petroleum emollient can be helpful for these babies. The babies who are born more than 28 weeks to 32 weeks, still they require sterile care as much as possible under the precautions. And in this care, you can involve the mothers, but you have to teach them for first 4 or 5 days how to take the boiled water, how to put it in the sterile bowl, in the sterile swabs, and then use it, right? And then teach them. Once you feel that mother has learned it, then you involve her in care. Otherwise, you have to wait, right? The babies who are more than 32 weeks, we can apply mild soap with low pH after 2 weeks. So these are the guidelines that have been concluded by Johnson DE. You can review and refer to these guidelines, a very beautiful article being written, and you can learn from this. Then skin care, if perineal care we talk about, perineal cleansing and protection. First 2 weeks में warm sterile water से wipe करना है. After 2 weeks, warm tap water wipes can be used. Do not use pre-packed diaper wipes until 37 weeks, corrected gestational age. Light protection, you can use 6% dimethicone cream and petroleum-based clear barrier ointment for the thick protection in the perineal area, because वहाँ perineal area से भी कई बार baby को infection हो जाता है if you are not taking care of that area. So it is important to take. I have given my slides in the group. You can review and learn from them, right? And zinc oxide paste can also be used. And for skin preparation for the procedures, 70% alcohol, 2% chlorohexidine, or 5 to 10% betadine is being used. But each one of them has their own limitations and side effects. तो ये नहीं है कि liberally लगा के छोड़ दिया और procedure करने के बाद. So you have to clean it. Clean it after the procedure with a sterile, normal saline or water. IV cannula लगाया, clean किया, डल गया, उसके सराउंडिंग एरिया का जो भी एरिया रहेगा ना उसको क्लीन करना है बाद में, या आपने कुछ ट्यूब डलवाया है, कुछ भी, whatever procedure, clean it because it get absorbed from the newborn skin very easily and create problems for the baby. Hypothyroid and all, there are a number of complications with use of each one of them. So इसमें कोई गोल्ड स्टैंडर्ड नहीं है कि कौन सा यूज़ करना है, बट ये रिकमेंडेशन फॉलो करा तो अच्छा है, उसको क्लीन किया है, right? Use medical adhesives like hydrogel EKJ leads, thoughtful tape selection. Use silicone adhesives for for the lines. Use silicone as contact layer under more aggressive adhesive when it is appropriate. So adhesive removal के लिए you can use Sensi Care. It's a spray, so you can use it in minimal quantity to remove the adhesives. Otherwise baby का skin भी साथ में आ जाता है ना, so that can be used. So these are the components of family integrated care. This is a part of my PhD project, and these are the components we have identified: respect and dignity, information and counseling, and assess the needs and problems of the parents. Usually we should interact with the parents. In our units, I have interacted with many mothers, and I found that mothers were already in depression when they delivered the baby. Then baby came inside the ICU, seeing the baby's condition precipitated their depression. They had more of crying spells, but nobody addressed their problem because we are focused only on the parents. So you should refer them to psychologists. Empower, educate the families in the care, inform decision, collaborate with the team. All members should collaborate together before making a decision and then inform the parents. And the other component is promote parent-infant interaction. Liberally we should allow parents to come inside the units, and then parent-to-parent support. So have you heard of this component earlier, parent-to-parent support? Have you heard of it earlier? This is a concept which is very famous and known in the Western world. In parent-to-parent support, we encourage the older mother to counsel the newer mother and to learn from them. So this will help them to build up a confidence. क्योंकि newer mother को लगता है कि अगर इनका baby 800 ग्राम था 1000 का था, 1200 ग्राम का था, इनका बेबी रिकवर किया है, so more likely my baby will recover. She will share her problems, anxieties with the mother, and the new mother will learn from her. So we involve in our unit, like in the evening time, 8 or 9 is time when we teach mothers skin care. So at that time what we do, sometimes we take a older mother to teach newer mother in our supervision. So, and later on they can interact and talk to each other. So this is called parent to parent. And we have also created WhatsApp groups of the parents. तो एक ग्रुप बना के हमने उसका QR कोड अपने यूनिट के बाहर लगा दिया. And now all the parents, जो भी new parents हैं, वो उसको QR कोड को स्कैन करके they enter into the group and they can ask their questions. So जो old mothers हैं, old fathers हैं, वो queries को resolve करते हैं. Fathers का अलग group है, mothers का अलग group है, because there was some privacy issues. Earlier it was a common group. Then we divided into 2. So that can also be done. So उसमें आप बीच बीच में कभी कभी चेक इन कर सकते हो कि किसी ने कोई गलत इन्फॉर्मेशन तो नहीं दिया है and all those. So we are doing it in our unit. So summing up, avoid all these hypos: hypothermia, hypoglycemia, hypotension, hyperoxia, hypercarbia, hypovolemia. And in conclusion, we need to have a dedicated teamwork, meticulous monitoring and monitored use of oxygen, infection control, aggressive nutrition, gentle ventilation and humane approach for all our babies. So these are the references. This, the first one is the chapter which I have written. It's an extensive chapter on nursing care. You can read from the book, you can photocopy it or whatever. So this is the role of nurses in NICU. This is published in Singh Meherban, and rest others are the references that I have used. So that's all for my presentation. Thank you.
Thank you, Gitanjali, for that elaborative talk. Now the floor is open for the discussion. Both the virtual participants also, if you have any query, please you can ask now. Or if any of you have any clarification needed. Okay, thank you.
Excellent, just a comment.
Yeah, sure.
And this family integration of what you have brought, actually we would like to know more about it, but maybe...
Yes, we have also created an app.
Questions?
It has got a set of videos, 14 videos, can be downloaded from Play Store, to FIC PGI करके, you can search. उसमें हिंदी का वीडियोस, इंग्लिश का सब डाला. उसमें ये सब स्किन केयर कैसे करना है, हाउ टू वाइप द स्किन, हाउ टू प्रोवाइड द बाउंड्रीज, हाउ टू एक्सप्रेस द मिल्क. बिकॉज हमारे सेटअप में प्रॉब्लम ये होती थी, हमारे डॉक्टर्स और नर्सेज दे आर वेरी गुड, दे वांट टू हेल्प दी पेरेंट्स, बट इतना ज़्यादा रश होता है कि एक बार एक्सप्लेन करने के बाद उन्हें दूसरी बार बात करने का मौका नहीं लगता. और जब वो पेरेंट्स जिस टाइम फर्स्ट टाइम हम उन्हें सिखा रहे होते हैं, दे आर इन अंडर ह्यूज स्ट्रेस एंड टेंशन, दे डू नॉट लिसन एनीथिंग. उनको कुछ सुनाई नहीं देता. मदर्स कहती है हमें सिखाया जिस तरह, लेकिन मुझे ना कुछ भी दिमाग में नहीं गया, क्योंकि मैं बच्चे को देख के बहुत डर गई, मैं एंजाइटी में हो गई, आई कुड नॉट डू दिस और दैट. तो उनको समझ याद ही नहीं रहता कुछ. फिर नेक्स्ट टाइम में वो जाएंगी दोबारा से, सिस्टर इतनी सी बात है कि डाइपर को फोल्ड करके नेवल से नीचे लगाना है, मदर ने फोल्ड करके लगा दिया, देन शी गेट अ स्कोल्डिंग कि तुम्हें पता नहीं रहता है ऐसे करके. सो नर्सेज ऑल्सो गेट इमीडिएटली कितनी बार बताएंगे. So all those small things, videos have been embedded in that, and there are some pamphlets also in our app. So we see refinement अभी चल रही है, but still it's working. So you can download and use and give it to your mothers to learn कि कैसे डाइपर लगाना है, कैसे सक्शन करना है, ऐसा में कैसे स्किन केयर करना है, all those things. वो mothers को करना है. वो तो हमारा WhatsApp group है ना. We created a WhatsApp group. We created 2. Earlier we created 1 only for the mother and father both together. So mothers they complain कि fathers are reading our messages and sometimes they comment which is not appropriate. So we separated the group. तो वो QR codes बना के हमने अपने यूनिट के बाहर लगा दिया. So parents they come and scan the QR code and they get enter into WhatsApp group for the parent to parent support. So they keep asking questions. तो पुराने mothers उनको answers करते रहते हैं. जैसे father हमारे setup बहुत बड़ा है, किसी को सैंपल देने जाना है, कहाँ जाना है, कई बार पता नहीं चलता, तो वो आंसर करेंगे. या कई बार मदर डिस्चार्ज होने के बाद पूछते हैं हमें वैक्सीन के लिए कहाँ जाना है, BCG के लिए कहाँ जाना है, या कुछ भी वट एवर देयर क्वारीज, क्या मैं बेबी को ऊपर का दूध दे सकती हूँ, या मेरे बेबी को डायरिया हो गया मैं क्या करूँ. So all those things. I also supervise in that group. So this has helped us in reducing number of babies getting admitted because of diarrhea and dying. This was a follow-up for our study. So this has helped many parents. So I immediately tell them कि अगर diarrhea है, ये issue है तो ऊपर का दूध नहीं लो, मतलब देना ही नहीं है ऊपर का दूध. And immediately you go to the physician. They start asking solution here and there, then वो timely अफजल नहीं होता है. So this has helped us in that way.
And you will monitor that group.
हाँ, I monitor that immediately. Keep checking. जो भी questions आते हैं वो check करते हैं. मदर ने आंसर ठीक किया तो it's okay. If I find the answer is not correct, so I.
Parent interaction is very good for
confidence
वरना
मदर्स को हमेशा स्ट्रेस में रहता है कि पता नहीं है बच्चा ठीक होता है कि नहीं होता है. तो ओल्डर मदर्स घर जा रहे हैं या घर जाने के बाद भी अब वो इंटरेक्ट कर रहे हैं, कभी अपने बच्चों की फोटोज पोस्ट कर रहे हैं. सो दैट गिव देम कॉन्फिडेंस.
So if there is no question, I think we can wind up here. And only the advice is whatever the knowledge you have gained. I think when we are monitoring, what we look is what we know. So what knowledge you have gained, so you will look into that with that in background, so that we can translate the knowledge into practice. So with that note, I think we will wind up the session over here. Next.
Before lunch break.
Oh, now we have Shriyan Ashwit sir. Welcome back, sir. You have a talk on transport of sick neonate. So you can start. So can we put the presentation or will you put, sir? Can we share the slides or you will share, sir? Unmute. Oh.
Give me a minute.
So can we play the PPT?
Are you able to share the slide from your side?
Yes, sir. We'll do that, sir.
Yeah. Yeah, this is I think lunch is very near. I'm going to keep it very short and sweet. Okay. So, we are going to discuss about your transport of a sick neonate. Moving on to the next slide. All kind of transports which can occur should always be pre-planned or a prepared transport. It can be either intra-hospital or inter-hospital. Whatever may be the scenario, it should be always be a planned transport. Next slide. So what is the need of transport? There can be different needs. The need first should be established and identified. Example being a baby which is weighing less than 1000 grams or gestation age is less. Basically, you're dealing with a preterm, premature baby which cannot be handled by your unit. Second possibility being a child with severe respiratory distress. That in baby requiring a ventilator support or higher level of care, which again is not within the scope of the unit. Shock, not responding to fluid boluses and vasopressors. That is again facilities that is per se which are required for management of such a baby is not available in your unit. Children requiring having a major congenital malformations. So basically specialized care or your specialists that is involved in these care are not ready. And children presenting with refractory seizures or those having your surgical abdomens. So those are all your referral patients. How do we need to get ready for transport of these babies? You need to first stabilize the baby. Again, as mentioned in the earlier sessions in morning, everything, that is your temperature, airway, breathing, circulation and maintenance of blood sugar. Temperature, basically the child should be adequately wrapped or warmed in your warmer, or you can have a jacket that is maintaining the temperature. Airway, basically a child requiring either your oxygen or nasal prongs, or if the child is ventilated, see that the ET tube is in place. Maintenance of the breathing, so take care that the child is adequately ventilated. Have your pulse ox saturation monitor in place. Maintenance of the circulation to see that all the IV fluids are running, the cannula is secured. Maintenance of sugars, see that the sugar is normal before the transport of the baby. In case if the need of antibiotic is there, you should give the dose of antibiotics. Any necessary treatment which needs to be done should be done prior to the transfer. You can't decide on intubating while traveling itself only. It is just like a cooking in a moving kitchen, so that is not possible. So any idea that the child might look likely to collapse, then better is intubating prior hand itself only. Check whether the oxygen is there in place. So all the fuel gauges should be checked. So oxygen is there, air blender is there, everything in your ambulance is ready for go. Next. Paperwork and the team. So counsel the parents and the family before transport. Basically, again, the parents should be mentioned what is the need for the transport, what is the necessity for the transport, and the people involved in the decision making process, their signatures, everything should be taken in. This is where again I mentioned as previously, documentation is more important. Again, communication. Now this communication is between from the hospital from where we are referring the patient from and to. So basically write whatever details that you can provide regarding the birth event or the nature of the delivery or any antecedent event, that is your antenatal history, anything that is available which will be helpful in the treatment and management of the baby, as well as the drugs and medication which have been given, the time noted and what time was it given. So all these things should be communicated in the referral letter. Arranging for a capable healthcare provider, relative as well as the nursing staff to accompany. That is again most important. When we say a capable healthcare provider, basically a person who is trained in newborn resuscitation as well as management to take care to give your necessary drugs and medications. So in case if the ET tube is displaced, the person should be capable of re-intubating. If the cannula is out, the nurse should be capable of re-inserting a new cannula. Obviously not on the go, please stop the ambulance when required. Assemble for all the supplies and equipment that needs to be used while transportation. So this is more important. Move on to the next slide. So here we'll be seeing what are the equipment and supplies that are needed, that is your drugs and fluids. So things that are required is those that can help in providing the baby adequate warmth. So that is covering the head, the cap, socks, source of warmth, that may be the warmer or the blanket, resuscitation equipment, bag and appropriate size mask, a neoprof resuscitator if in case your ventilator doesn't work as expected, suction apparatus, it may be a foot operated one, that is better, oxygen cylinder with a flow meter and see that the oxygen cylinder is filled up to the mark, nasal catheter or head box, stethoscope, thermometer, ET tubes, laryngoscope blades with appropriate sizes, ICD drains if required, laryngeal mask airway if we are not able to intubate in case. Those baby which are on oral feeds, express breast milk, see that the orogastric tube is in place. Those on IV fluid, see that the IV infusion set is running, the cannula is in place. If in case needed, necessary needles, syringes, adhesive tape, sterile gloves and antiseptic solution for the same. A source of illumination, that being your torch or in cold light to check for any pneumothorax on the way. Drugs and fluid, basically all IV fluids that are necessary for resuscitation, inotropes, sedatives, anticonvulsant and all resuscitative medication should be there in stock. Next. During all this, we should not lose the track of the target. Basically, at all given point of time during the course of transport, the baby should be monitored. Again, talking about monitoring, that being your temperature, airway, breathing, circulation, your IV cannulation and infusions, everything should be in place. Ensure that the baby is getting adequate amount of feed or fluid. See that the baby does not go into shock. Oxygen if and as and when indicated depending on your pulse ox saturations. As mentioned earlier, stop the vehicle if the need and necessity to manage any of the complication or problems arises. You can't intubate a child in a moving van, neither can you put an ICD if the need arises. I would request Mr. Lokesh or somebody to mute themselves. Thank you. Moving on to the next slide. At the end of the event, basically the feedback from the team where the referral has been given. The condition of the baby at arrival as well as the outcome of the baby as well as the handover should be given to the referring hospital regarding the treatment and the management that was done for the baby. Later on, having a communication with them, post-discharge advice and follow-up should be taken care of. Thank you. I kept it very short and sweet as the time could permit only this much. Thank you.
Thank you, sir.
Next. Yeah. Thank you. I think everybody is breaking for lunch.
No, sir. Everyone is pretty hungry. Thank you, sir. Thank you very much. Thank you, sir. Thank you very much. We'll take a break now. We'll meet after exactly in half an hour, so that
lunch is long due for everybody. I think everybody should break for lunch now.
Yes, sir. Yes, sir.
Yeah.
Thank you.
Thank
you, sir. Thank you.
Thank you.
Working as lecturer at College of Nursing, National Institute of Mental Health and Neurosciences, Dimans, Bengaluru, and she has many awards in her credit, and she is a very active member of Indian Association of Neonatal Nurses and NNF, and she is master trainer for nurses on Ascension Newborn Care, trainer for training of nurses on facility-based care, national faculty for advanced life support, and facilitator for conducting workshop on neonatal resuscitation and program. And she has many publications in her credit. So, ma'am, I welcome you to moderate the session, please.
Thank you, Gitanjali. Good afternoon to one and all. We are beginning with the afternoon session now. So, to begin with the afternoon session, we have our speaker for today, Dr. Aruna Divakar. She has completed her pediatric in Kanchi Kamakoti Child Trust Hospital, Chennai, and she has fellowship in neonatology. So, presently she is working as a consultant neonatologist at Sparsh Hospital, Bangalore. So, I welcome Madam for today's presentation.
Thanks, Dr. Jiva. Nice to know that our nurses, neonatal nurses, are doing so much work for our newborn babies. I would start by thanking the NNF and the organizers for this opportunity, and feel happy to be a part of this prestigious National Neocon. So I will be today's session will be on kangaroo mother care. I will be covering on basics of KMC. This will be followed by video demonstration of KMC and breast milk feeding by Dr. Manisha. So starting with KMC, I'm sure all of us know what is KMC. So going by a little more elaborating on this, it is an evidence-based, humane, low-cost, high-impact, standardized method of care of preterm and low birth weight babies. Evidence-based we say because there is significant literature, randomized controlled trials, research, reviews, studies are there on KMC. And the Cochrane reviews in 2016 has compared KMC with the conventional NICU care, and it states that mortality and morbidity is significantly lower in KMC babies. Humane as it is a family-centered approach and mother is the predominant caregiver. Cost effective as KMC involves an early discharge always, that you will get to see. And it's associated with less hospital-acquired infection, making it more cost effective. high impact as the breastfeeding rates are much better with KMC, and also mother and the alternative KMC providers who are the caregivers feel less stressed while give KMC. They are more confident, they are more motivated, they feel more empowered to take care of their baby compared to conventional caring. This KMC has been around for almost 4 decades now. It was started in 1979 in a city called Bogota in South America. WHO defines KMC as early, continuous, prolonged skin-to-skin contact between the mother and the baby. Skin-to-skin contact alone cannot become kangaroo mother care. In addition to skin-to-skin contact, there always should be exclusive breastfeeding ideally. If that is not possible, predominant breastfeeding. It is to be initiated in the hospital and to be carried at home. And it always involves an early discharge with follow-up with adequate support. So these are all becomes the components of KMC. KMC is definitely beneficial. There is no doubt about it. It has both short-term and long-term benefits. So KMC is starting. How does it work? Starting with the temperature regulation, which works through neuroendocrinal mechanism. The skin-to-skin contact between the mother and the baby causes release of oxytocin in the mother and the baby. In the mother, it acts as a hormone and it's responsible for let-down reflex. It also stimulates certain areas of brain, parasympathetic system in the mother, causing temperature regulation in the baby. And the circulating oxytocin causes cutaneous vasodilatation in the region of the breast. So that the breast and the chest regions, especially during feeding or during KMC in the mother, is always warm. It so happens that there is a thermal synchrony between the baby and the mother develops, and this baby maintains a narrow range of temperature while in KMC position compared to the same baby in an incubator where there is a lot more temperature fluctuation. So temperature control is definitely better with KMC. KMC increases the duration of sleep, quality of sleep, and better sleep cycles. Normally we say a baby requires about 1 hour of sleep to complete a sleep cycle. As we all know, babies have non-REM sleep, which we call it as a quiet sleep. Then preterm babies have something called as a translation sleep, and there is a REM sleep, which is an active sleep. The whole discussion of sleep happens because the non-REM sleep is responsible for the long-term memory, cognition, and learning in babies, whereas the REM sleep is involved in the development of sensory system, as in hearing, vision, smell, touch, taste. So these all system in a baby develops best during the sleep. KMC reduces stress in the babies. In the morning, I think we have had session with Dr. Kiran where he has mentioned about the pain and how painful kind of NICU environment is. Very true. NICU is a very stressful environment because one, they are separated from the mothers. We always handle them. There are so many procedures we do on the babies. And as he was always telling you, there is bright lights, the dimming. Some of the NICU do, some of us don't have the dimmers, and it's kind of a noisy environment. So prolonged stress, these babies continues to stay for a long time with us, and prolonged stress leads to increased level of cortisol in the baby. Cortisol increase can always lead to disruption of the normal brain development in the babies. The wiring, what we say, the synapses of the neurons are affected because of the cortisol level. There has been a long-term studies where these KMC babies have been followed up for 20 years of life. This has come in a Journal of Pediatrics in 2016. This states that these KMC babies at 20 years, they found that they did better in school, they did better in college, the mother and the child bonding was better in these babies, and neuroimaging done at that time found that these babies had higher brain volumes. So finally what it means, reducing the stress means we are giving mothers babies who have better intelligence and better IQ. So whenever we are promoting KMC, we can always say that your baby is going to become smarter, your baby is going to be having a better IQ, which I don't think any mother would not want to have a smarter baby. It reduces infection because it reduces transepidermal water losses, improves the hydration of stratum corneum, improves the barrier function of the skin. Thereby there are less hospital-acquired infection. Overall better immunity happens because there is better breastfeeding rates and reduced stress. All the physiological parameters show significant improvement. Like when a baby is in KMC position, the heart rate is much lower, it breathes more regularly, the oxygen saturations are a little higher compared to the conventional care. Similarly, temperature regulation, as we also is better in KMC position, and sleep cycles are better in these babies. Overall, the growth is better in terms of weight gain and head circumference. The breastfeeding rates at discharge is better, and there is a better maternal and family-centered care and a better satisfaction. And KMC significantly reduces mortality at discharge. There are three components. Now coming to the actual KMC, there are three components in kangaroo mother care. One is kangaroo position, kangaroo nutrition and kangaroo discharge. Kangaroo position is nothing but skin to skin contact between the baby and the mother. Nutrition involves breastfeeding, as I was mentioning, which we try for exclusive breastfeeding. And kangaroo discharge involves an early discharge from the hospital. If you look at all these, the picture on the right hand side, all these three are surrounded by a supportive environment. The supportive environment has to be created by us who are the healthcare workers, the nurses and the doctors. The family has to participate. That will happen only when we counsel them. And also we need to give an adequate follow-up of these babies. Should be done because they get always discharged early. And the best time to counsel a parent or a family about KMC is during the first antenatal visit, because they may not be aware of a concept of KMC. So during the antenatal visits, we will have to tell them about KMC, and then we come into picture as and when the mother delivers the baby. So this slide basically, here we look at the steps of kangaroo position. Kangaroo position is the first component of KMC. How to go about putting the baby on the mother's chest. Before doing anything, hand hygiene is important. Then place the mother's, get ready with the mother's clothes, baby clothes, and there is a special item in KMC which is called as the binder. We will talk about it later. It's just nothing but a piece of fabric which holds the baby and the mother together. The mother should be wearing a loose-fitting, comfortable front open clothes whenever she does KMC. For the baby, you should wear a hat, diaper and socks. And whenever we start the KMC, the baby, starting, you hold the baby with head and neck supported with one hand. The other hand hold the baby's bottom, and the baby is placed vertically on the mother's chest in between her breast, such that the baby's neck should be neither flexed nor it should be too extended. What we describe as slightly extended in such a way the mother should have an eye-to-eye contact with the baby, and she should be able to see the baby's face. So after putting the baby in this position, then we apply the binder to hold the mother and baby together. The upper edge of the binder, if you see in the third picture, should be at the level of the baby's ear. The lower part of the binder should cover the baby's bottom and the legs, which is in the fourth picture. Then check on the binder. Once you have done this, check on the binder. The binder should be neither too tight, which affects the baby's breathing, nor should it be loose where it kind of slips down. Because in this position, if the mother and the baby both are stable, then the mother can continue to do her activities of daily living. Sitting, standing, walking, simple activities in the hospital or at home, she can carry forward. So make sure that the binder, you have placed the binder in the right way. And after this, again hand hygiene. And you button the mother's gown and put an extra blanket around the baby and the mother for the warmth. So how long should the baby be in this kangaroo position? We say in one session of KMC, the baby should be there at least for 1 hour, because as we already said, one sleep cycle takes about 60 minutes in the baby, and the baby always, the brain grows during sleep. So ensure that minimum 1 hour session should be there. In practice, what we practically say is 1.5 hours of session, so that an effective 1 hour is achieved. Shorter duration is not beneficial to the baby, because you are removing the baby from the isolate, handing over to the mother, putting it back. It's again very stressful for the baby, and the baby sleep cycle also gets affected. So always ensure minimum of 1.5 hour cycles during each session. And then based on how long we give the KMC, we call it something called as intermittent KMC and continuous KMC. Intermittent KMC is done usually initially when the babies are in NICU. They require a lot of monitoring, intensive monitoring is happening. And generally these are done only for few hours with long breaks in between the session. So generally this KMC, this intermittent KMC happens in the NICU or in a KMC corner which is close to NICU. Here the baby will be receiving KMC as well as conventional care. This intermittent KMC can be done even when the baby is on oxygen. It may be on a CPAP, high flow nasal cannula. The baby may be having IV for parenteral nutrition, IV fluids may be going on. Sometimes they may be having umbilical lines. Even with all these things, based on your unit protocol, it can be done, but each unit has to devise their own protocol for KMC. Then only based on the unit protocol, you will decide on which babies can go on to intermittent KMC. This is just for an understanding, saying that even with all this, the KMC can be done. Even when the babies are getting stabilized, KMC can be done. Then next, as the baby becomes more stable, then we move on to continuous KMC. This is done ideally in the KMC ward or in the private rooms. We call it continuous if it is more than 12 hours a day. Here it should be more than 12 hours, and the mother takes only breaks only for her hygiene, or you remove the baby for the baby's hygiene or a clinical examination, and sometimes cup feeding. Ideally, we say the KMC break should not exceed more than 30 minutes. Within that, the baby should be again put back into the kangaroo position so that the maximum benefit should be achieved. And the support at this stage of continuous KMC, the supportive family is also required, because when it is 12 hours or continuous 17-18 hours, then sometimes the alternative KMC provider from the family also can give kangaroo position to the baby. It's not only the mother, it can be the father, it can be the grandparents who can become alternative KMC providers. So finally, the longer duration, it is better, and the impact with KMC is also better. So when to start, when do we initiate KMC? If all babies who are less than 2000 grams, ideally it should be done. But any baby who is between 1.8 to 2.5 kgs, usually these babies are stable at birth, and we can initiate early KMC. Early KMC means starting KMC within 24 hours after birth. So babies who are between 1.2 to 1.8 kgs may require a little bit of oxygen. They may be on a CPAP. We might have put some peripheral arterial line to monitor. They may have an umbilical venous line. They may be on IV fluid. As long as these babies are hemodynamically stable, even these babies can go on to early KMC starting within 24 hours. 1.2 kgs and lesser than that, usually few days will be required before KMC is started, because these babies who are less than 1.1 kg of weight, usually the temperature stability in the first week of life when we put in the KMC position may not be very good. So who does the KMC? Mother is of course the best KMC provider, but there are alternative KMC providers. The healthy fathers and the healthy grandparents too can give KMC. Where is it done? Intermittent KMC usually happens in the NICU or in a KMC corner, which is either in the NICU or close to the NICU. Continuous KMC happens in the ward and the private rooms. And at home also, after discharge, the mother can continue with the KMC. So here you see a picture of father doing a KMC. Even for for twins also, it is possible to do KMC. You can see the mother, where one is on CPAP and the other one is a stable baby. She is going ahead with the KMC. Take care whenever doing the KMC that the room temperature should not exceed more than 25, should not be less than 25 degrees, and it should not be very noisy. So certain KMC requirements is every unit should have a written policy or guidelines which are adapted from the national and the international guidelines. So this policy should state at what birth weight you will start, what gestation age, and the time of initiation. All this depends on the unit protocol as well. Mother's requirement will be adjustable bed, a comfortable reclining chair. In case an adjustable bed is not there, provide pillows and clean sheet in a propped up position where she can be in a semi-recumbent position and do a KMC. So make sure the mother has privacy by putting curtains in the area where KMC is happening. And she should have a daily shower, mandatorily, hand wash facility with a running tap water round the clock should be there. Recreational activity, educational activity can be there for the mother when continuous KMC is being given. The only special requirement in KMC is a good support binder. Now there are a lot of commercially available binders as well, where in the workstation we will be showing that, what we call KMC slings and bag. Indigenously also it is able to make KMC binders using a long towel or a dupatta, plus some warm clothes to wrap the mother and the baby. A breast pump if possible, so that the mother will not have hassles of expression of milk. And make sure the mother's personal hygiene is good, like in terms of she has a bad daily, her nails are cut, she doesn't wear any jewelry during KMC like long chains, bangles, rings, all these to be avoided. And she's wearing a comfortable, loose-fitting front open clothes, and she can continue to do her simple activities. Baby's requirements is a cap, socks and diapers. The other equipments required are a thermometer which can measure up to 35 degrees centigrade, a weighing scale which can document even 10 grams of weight, and basic resuscitation equipments and medication as per the hospital policy. So every baby should have a KMC sheet where the initiation date, time, gestation age, weight, everything should be documented. One thing is the mother herself can every day log into this case sheet, where the starting time and ending time she can mention, and the total duration she has given in that day she can mention. And that kind of how she's been feeding the baby she can mention. And the weight gain, whatever every day the baby is weight, she can document that as well. This makes the mother more empowered. Looking at the baby's weight gain and looking how long she's been given, she will start doing much better. Coming to the second component of KMC, which is the kangaroo nutrition, this deals with nothing but exclusive breastfeeding or predominant breastfeeding to the babies. If the baby is 34 weeks and older, they can do a direct feeding in the kangaroo position itself. So the first picture shows a mother who is giving KMC. The baby is in kangaroo position and taking the feeds. Between 30 to 34 weeks of gestation, breastfeeding can be initiated, but they may feed a little slowly initially. The sucks may be a little slow. These babies, you can give supplemental feeds as express breast milk through a cup and spoon. Sometimes tube feeding also may be required. 30 to 32 weeks of babies usually require tube feeds initially, and later on, and they will be started on cup feeds initially once or twice, and then gradually as the gestation age advances, they go on direct feeding. So the third picture, you can see in the baby in the kangaroo position receiving tube feeds. It is possible to do the tube feeds. In the same kangaroo position, a mother is doing cup feeds as well. A mother can express breast milk even in the kangaroo position also. So this is ideally, this is what a mother should be doing. In the kangaroo position, she should be expressing and feeding the baby in the kangaroo position itself. Whenever you talk to the mother, always reinforce on what is a good position and good attachment to the mother, and teach the mother all about to express breast milk in the kangaroo position, and frequency of expression, collection, storage, all this should be kind of taught to the mother. This is just a slide just to show what is a good position, what is a good attachment, and how to help the baby attach to the breast in the kangaroo position. So what do we monitor, whom do we monitor during KMC? All babies in KMC have to be monitored. There are some high risk babies like who are on CPAP, on HFNC, very extremely low birth weight babies. These babies require much more intense monitoring, twin babies, sick babies, and mother when she is not confident of giving KMC. What should be monitored? So starting with temperature, one, you can teach the mother all about touch technique, which I think in one of the sessions in morning, which we covered during the vital parameters in NICU babies, this touch technique was covered with the dorsum of the hand. Ask her to touch the hands and feet, and you tell her it should always feel warm. That indicates the baby is maintaining temperature. The WHO guideline states that when the KMC is initiated, once in 6 hours the baby's temperature should be taken, that is an auxiliary temperature should be taken. Keep the thermometer for 3 minutes, and it should be done for 3 consecutive days. And when the baby is maintaining temperature, then you can make it twice a day, once in about 12 hours. Supposing when the temperature is being monitored and we notice that the baby develops hypothermia, then these babies every hour they should be monitored for the next 3 hours. At the end of 3 hours, if the baby continues to have hypothermia, then as per the unit protocol, these babies have to be investigated as to what is the causes. Common could be sepsis. And if the baby continues to maintain temperature, you continue with the kangaroo position. And in the airway, as already mentioned, the baby's neck should be turned to, head should be turned to one side, neither too flexed nor extended. Keep it in a slightly extended position such that the mother has an eye-to-eye contact. She is able to see the face. This indicates the patency of the airway. Breathing, you can provide a mother a 1-minute timer and teach her to count respiration for 1 full minute, which is normally 30 to 60 in a minute. Then teach the mother to recognize what is fast breathing, more than 60 in a minute, irregular breathing. Then baby having chest retraction, the grunting sounds, apnea, all these things should be taught to the mother. Demonstrate to the mother by asking her to hold her breath for a short time, like less than 20 seconds, and ask her to hold a breath for a long time, more than 20 seconds, to make her understand what is apnea. And then when the mother notices the baby has apnea, you should teach her to stimulate the baby either by patting the back or stimulating the toes, and then immediately contact the healthcare providers. Color of the face, whenever the mother looks at the face, it should look quite pink, not pale, and the lips and mouth color, if it looks kind of blue, immediately to alert the healthcare worker. Feeding, always encourage feeding and expression in kangaroo's mother in the kangaroo position. The weight should be recorded every day. These are the danger signs which we have already discussed. Immediately when the mother notices the danger signs, she has to contact the healthcare providers. Certain do's and don'ts in KMC, who can help the mother to give KMC? healthy parents, healthy grandparents can contribute as alternative KMC provider. Do not allow children. Anybody who has cough, cold, fever, if the mother herself has a viral infection, viral illness, don't allow her to do KMC. Anybody who has, you notice having a skin infection, like some boils, abscesses and all, such either parents or grandparents should not do KMC. And anybody who has any mental illness, who was on a prescription medication, should not be doing KMC. Similarly, any infectious diseases which can transmit by direct contact, like chickenpox, these parents should not be doing the KMC. So the parents may commonly ask, how do we make sure the baby doesn't get an infection in the hospital? All the members to practice hand hygiene before touching the baby and ensure that the baby is in a continuous KMC, which will automatically reduce the infection rates. And how do we support family to practice KMC properly? This I think Geetanjali also had mentioned about parent-to-parent support. This is where it comes, where the experienced families will coach the new families on KMC through demonstration on their own baby, and the families will tell the starting families about what kind of challenges they had and how they overcame the challenge and how successful they are with their KMC. And similarly, the health staff, whenever they see a mother or an alternative KMC provider giving continuous KMC, then these people should be praised and positive. It acts as a positive reinforcement for the entire family. Kangaroo discharge is the third component of KMC. Early discharge always happens in a KMC because the baby is discharging the kangaroo position. Here the weight and gestation age is not taken into consideration at the time of discharge. Here when the baby is able to suck, swallow, breathe, coordination is there. Baby is gaining 15 gram per kg per day for the last 3 days, and the baby is maintaining temperature in the kangaroo position in the last 3 days. It means that these babies are ready to go home. In addition, there are other discharge criteria as well, and once these babies are discharged, make sure you tell the mothers that they have to continue KMC even at home. So certain mother and baby criteria is mother's physical and mental health should be fine, because she is the one who will continue KMC at home, because you will be discharging a low birth weight baby home. Mother, ensure again you run through all the pre-discharge checklist, run through all the things that she is adequately trained, proper practices hand hygiene, her technique of breast milk expression, breastfeeding, collection, storage, all these she is aware, and the family should be supportive, and they should act as alternate KMC providers at home, because it is going to be a continuous KMC at home. The baby, as already I said, should be free from infection and apnea, should be gaining weight for 3 days, and should be maintaining temperature. And one more important thing is the discharge card. The discharge card should be filled properly, and in the discharge card the follow-up date, follow-up time and the follow-up place, all these 3 things should be mentioned, plus you should reinforce the parents and the grandparents about the need for follow-up and where exactly and when they should come back for a follow-up. So if the baby is less than 37 weeks during the follow-up, then they have to be seen 2 times a week. If they are between 37 to 40 weeks, then 1 visit per week is sufficient. And once they cross 40 weeks, they go on to the routine well baby checks they go on to. The only thing, these KMC babies will have a special neurodevelopmental follow-up clinics, which they will be doing in between 3, 6, 9 and 12, corrected age of gestation they will be doing, and they will be continuing up to 5 years of age. So where will they be seen? In the same hospital where the baby was discharged, or any nearby hospital which is convenient to a family where they follow up the NICU babies. That should be there. It should not be any hospital, but NICU follow-up should be happening in that place. So you should be referring the baby to that kind of a center. District early intervention centers are there, which are very good. These babies can be sent there. When all 3 are not possible, then a home visit by a community health worker has to happen. So what happens during the follow-up? Again, the nurse or the community health worker sits with the mother, checks all about kangaroo position and kangaroo nutrition, how it's been happening at home. Any mother's concerns should be asked and should be clarified correctly. The weight, head circumference and the length, whatever the growth parameters are taken, they should be again plotted on the appropriate growth charts. This depends on the unit policy as to what chart we are using. The immunization date should be given. Always inquire on the supplements what the mother is been giving to the baby. Usually calcium, vitamin D, multivitamin, iron supplements will be there. Some babies will be also on the fortifiers. So just check whether she's been giving all of them in the right doses and how she's been spacing the supplements and how she's been giving them. Some preterm babies will have special follow-up visits for, they will have an ROP check, hearing screen at term gestation age, and also they will require a head ultrasound at between 37 to 40 weeks of gestation age. So make sure the dates are given for all these things and where they have to go, that also has to be mentioned. And when do we stop or wean the babies from KMC? We say at 40 weeks of postmenstrual age or when the baby becomes 2.5 kgs. Whenever a mother tries to do KMC, the baby starts fussing a lot, wriggling out, then starts crying. That means all this indicates that the baby is ready to get weaned from the KMC position. So where are we now? We said KMC started way back 40 years ago in 1978. And in 2003, actually, the WHO brought guidelines for KMC. In India, in 2014, the Ministry of Health and Family Welfare brought out the KMC guidelines. 2018, a zero separation policy was adopted where the mother and the baby should not be separated in the healthcare facility. In 2020 and 2021, we are talking about something called as immediate KMC and mother newborn ICU. So in immediate KMC, here I'll just talk about it very briefly. Probably Madam will be talking a little more on that, immediate KMC. So it's here what we do is at birth, these babies will be started on KMC even before stabilization. There has been a multi-country study, a randomized trial where 1 to 1.8 kgs babies have been started on immediate KMC within 2 hours after birth, irrespective of whether they are stable or not. It starts in the delivery room. The baby is in the KMC position either with the mother or the surrogate, and then is shifted to the mother and newborn ICU. With the respiratory support, they are shifted. So this is called as immediate KMC. This particular study found that there is a reduction in mortality by 20% in these babies as compared to when you start KMC after the babies are stable. Either ways, all of us will do KMC. Along with the NICU care, KMC will be happening. But here, the thing is the KMC starts right in the after birth itself. And something called as a mother, the way forward in the healthcare probably will be a mother newborn in ICU, where the mother and baby are kept together. You see the mother who is just delivered, who is there, and next to her itself is the warmer, and the baby can be put on a respiratory support there itself, and the continuous KMC keeps going on. So with this, I will end my talk on KMC, and thank you for the patient listening.
Thank you, Dr. Aruna. It was a very extensive presentation and a detailed note on KMC. I would like to add a few of that. We understand very well that it's a very simple, affordable method for care of low birth weight babies, because there is no resource required. We require only the mother and the child, which is already existing there. So we just need to invest time in teaching them how to go about it. And apart from the benefits what Madam has already mentioned above, like it provides effective thermal control, it increases the breastfeeding rate, because the breastfeeding rate is found to be very quite less. So this is one of the way where we can increase the breastfeeding rates. Then it promotes early discharge. It decreases the neonatal mortality and morbidity in case of newborn babies. So it has quite a lot of advantages. Apart from that, even the senses. We all have 5 senses, so that is also being promoted through this. For example, KMC satisfied all the senses in a newborn baby, like the baby feels mother's warmth by having a skin-to-skin contact. So it's a direct one, touch is being enhanced through this. Then the baby listens to mother's voice and the heartbeat, where the hearing is activated, and the emotional bonding is also enhanced during this particular process. And the baby is constantly placed in the younger mother position, where there is an ample amount of opportunity for the baby to suck and have adequate amount of breastfeed. So here the taste is being promoted. Then the mother and the child are going to have a frequent eye contact, because they are going to be held together always, where the vision and the baby will be able to have the smell of the mother. So where the olfactory function is also being enhanced. So along with the other innumerable benefits which KMC offers, KMC also promotes the normal growth and development in the newborn baby. So with this note, I would like to conclude the session. In case if there are
any queries to the participants seeing virtually as well as participants present here, you are welcome. The floor is open for discussion. Do you have any doubts, queries? Okay. Thank you all, and with this note, we will end the session. Thank you all.
Yes. Nice meal. Everybody enjoyed food? Good. So, yeah, I'm Dr. Manisha Bhandankar. I have been given it's a continuation of topic what Madam has very nicely covered for with regards to KMC. I was given the topic of talking about showing you all the videos on KMC and breastfeeding. Once we know this knowledge about how I'm sure all of you are working in the NICU? All are working with newborns? Yeah? Yeah? Okay. So, I mean, breastfeeding is something which must have been told to you in and out all the time, during your training, during your NICU work, the importance of breastfeeding. The same way about Kannuru mother care. You all know, you all have been practicing, and now you all added knowledge of why KMC is important, right? Now, the importance is, once we know how important it is and how good it is for the baby, the baby has to get benefited, and the baby will get benefited if the parents know about it. So from you, this knowledge has to reach to the parents. Okay? You would be starting KMC when they are in the NICU, but what about when the mother is on her own? What she should know about KMC, how to practice it, who is going to guide her? And sometimes, as we said, as Gitanjali was saying earlier, they are so stressed when they are in the NICU that whatever we teach them, they tend to forget. The same thing about breastfeeding. I'm sure you must have seen, those who have been working in the NIC, you must have seen that we teach them about breastfeeding, expression of milk, how to do katori feeding, everything we teach them. And then once they go home, then they come across with some problems, and then they'll end up with things which we don't want, like, addition of top feeding, this bottle feeding, all those things start. So somewhere all this knowledge what we have in this room should not remain with us, but it should reach up to the parents. It has to reach to the community. It is only then the baby who is the final beneficiary of it will get benefited. Right? So that is why when I thought, what am I going to talk to you all about videos, I thought I'm not going to tell you, because I'm not going to show you videos of what KMC is important, why breastfeeding is important, you all know about it. How are we going to tell the parents about it? How are we going to convince them to continue this at home? And that is when I thought I will introduce you to this particular project which was done by IIT Bombay. This was a wonderful project which they took up on creating what is called as health spoken tutorials. This was done in 2020, and they are available in various languages. To my knowledge, I know it's in English, Marathi, Hindi, I think it's in Gujarati, also various languages, and they're still adding on different languages to it. So if you can make use of these videos, and they're downloadable also. But I have not downloaded them because I wanted to show you how to access them online first, and there are a number of videos available. Okay, not just one or two. That is why I thought I will try to show you all as much as possible these videos which you can make use of to help the parents, so that you can show those to the parents when they are in the NICU. You can show the parents that you can access them once you go home also, and then if you have any queries, you can listen to those videos and get yourself, get your whatever doubts cleared. So these are called as Health Spoken Tutorial Project. This is a YouTube channel which was created by IIT Bombay. Okay, and it is all animated, and they started somewhere in it was basically in 2020 they started this project. So this is just one about what comparison of mother's milk with other substitutes, but better than that, I will show you some other videos. There are plenty of such videos. Come out of it. No, you go back, yeah. So you go down. See, there are plenty of these videos on breastfeeding. Yeah. Breastfeeding. No. You just put here health spoken tutorial breastfeeding. You put. Okay, you can put this one. Yeah, you can go on this one. It is start. Yeah. So you can look at these. Start.
Welcome to the spoken tutorial on breastfeeding latching. In this tutorial, we will learn about correct latching technique for deep attachment.
So there are each video is of 10-12 minutes. Okay, and there are multiple videos like this. I can't show you all of them.
Please note that for effective breastfeeding, correct latching is most important. Poor attachment of the baby's mouth to the breast will allow only nipple feeding. This will give very little milk to the baby. Whereas deep attachment of the baby to the lower part of the areola of the breast will give sufficient milk to the baby. Please note, areola is the dark area around the nipple. Now let us begin. To start with, the mother should hold her baby in a suitable breastfeeding hold. These holds are explained in detail in other videos of the same series. This tutorial will...
Okay, so there are, in this series again, each of these breastfeeding holds, how they are, again there are more videos about it. So you can sort of make use of them when you have to talk to the mother. Whichever part of this you want to show her, you can show it.
Will be explained using the cross cradle hold. Remember, positioning the baby correctly is necessary for successful latching and breastfeeding. In this picture, the mother is holding the baby correctly in the cross cradle hold, and the baby is ready to latch on for breastfeeding. Before latching, it is important that the baby opens her mouth widely like a yawn. Why? Let's understand this by looking at an adult eating vada pav or burger. We open our mouth wide to take a big bite of the vada pav or burger. Similarly, a wide open mouth will help the baby to take a big part of the breast in her mouth. To encourage the baby to open her mouth widely, mother should lightly brush her nipple against baby's upper lip till she opens her mouth widely. Be patient. Sometimes it may take a few seconds to 2 minutes for the baby to open her mouth widely. Remember, for any breastfeeding position, mother's fingers and thumb holding the breast should always be parallel to the baby's lips. When the baby opens her mouth widely, her lower lip should be at the base of the areola and the nipple should be aimed towards the top of her mouth and not the middle of her mouth. Now, mother should quickly put her breast in the baby's mouth. She should press the baby's chin into the breast first by slightly bending baby's head outwards. She should not bend her back or push her breast to reach the baby's mouth. Bring the baby to the breast by a gentle push from behind the baby's shoulders. The most important point in latching is lower part of the mother's areola should be in the baby's mouth. This will help the nipple to reach a comfortable area in the baby's mouth. Baby should be pressing her tongue against the part of the areola near her lower lip. This will compress the larger milk ducts and more milk will come out. Next step is to check whether the baby is attached deeply to the breast. To ensure deep attachment, mother should look for the following signs. Baby's mouth is wide open. The part of the areola visible near the baby's upper lip is more than that near the baby's lower lip. Baby's lower chin is completely embedded into the mother's breast. Baby's jaw drops distinctly as she swallows milk. And the baby's lower lip is curled in the outward direction. Although it mostly gets hidden in the breast in a very well attached baby.
Okay, so you can see how clearly they have explained each concept, each point, all right? And I will not go through each of these videos. You can take your time. They're all available online. Go through them and use whichever video you want in whichever situation you want to explain to the parents. And first listen to all those videos because it's a great this of knowledge which is there, and it will help you how to explain to the mother also. Okay. Similarly on KMC, I come out of this. You write there KMC, Health Spoken Tutorial KMC. This I'm just showing you so that you can also, and they are there. I think Kannada also it is there. No, okay. So there is of making of a KMC bag, then go into the second one. Yeah, the second one, no, here, this one. Yeah, okay. So there are different tools.
Welcome to the spoken tutorial on kangaroo mother care. In this tutorial, we will learn what
so
is kangaroo mother
Madam
care,
told you all just
the
now.
components,
Okay, all that to tell the parents, to tell the mother, you can use of this, make use of this.
Let us first begin with the introduction of kangaroo mother care. As the name suggests, it involves keeping the baby in skin-to-skin contact with the mother and is popularly known as KMC. Remember, KMC should be given as soon as the baby is born. It is especially recommended for low birth weight babies whose birth weight is less than 2.5 kilograms and who do not require continuous monitoring. However, it can be used for all normal, healthy, full-term babies too. KMC consists of two main components: continuous and prolonged skin-to-skin contact between the mother and her baby, and exclusive breastfeeding. Let's discuss these two components in detail. The first component is skin-to-skin contact. It improves the let-down reflex and ultimately increases the breast milk production. Let-down reflex has been explained in another tutorial of the same series. The second component is exclusive breastfeeding. Note that exclusive breastfeeding is recommended for the first 6 months. Next, let's discuss the importance of kangaroo care. Prolonged skin-to-skin contact during care.
Okay, so again the same whatever madam has explained, all that is there in this, and it is an animated format, so it is easy for the public, for the community, because we don't have to hear there's no privacy problems, all those issues are not there. That is why it has been prepared in the animated format. So you can use these tutorials to talk to the, first listen to them, you all go through them, and once you know which video will be useful for which parents, you can use them. And then there are more for the later part also, like weaning, complementary feeding, which one, how to start with the complementary feeds, which ones to introduce first. All that has been covered in these tutorials. Alright, so I think since we are running out of time, I will not cover more of this. It is all there on the net. Go through it, read it for yourself, listen to it, and use it as and when you require. Alright? Thank you. Okay, next is what? Panel or that? I think then one more talk is there, no, for me? No, and then the talk is there, which that is when? I have to continue with that talk, right, after this? Building and nurturing. So shall I talk about that first now? Yeah? Okay, you put that up. Okay, right. I was wondering why I was being given this topic to talk about by the organizers when it came to nursing workshop. So I have built it up the way I think those of all of us as a team who are working in the NICU, why is it important to have this concept in our mind, and how is it going to improve the newborn care? Finally, the whole thing, our goal is what? Our goal is to help that little baby who is there, who is most vulnerable and who cannot take care of himself or herself, and that is why we are all here, how we can do the best to ensure that that life is continued and continues to grow as a normal human being, basically. So let me tell you a story before I go ahead with my talk. How do I go ahead with this? Yeah. This is a story of Gandhiji and a little boy. I don't know whether you all have heard this. There was this mother. Gandhiji was in Sabarmati Ashram that time. There was this mother who had a child, and she was worried about her child was eating a lot of sweets. Okay, he was a real sweet lover. So she tried her best to decrease his eating of sweets. But somehow she was not successful, and I don't know why. She thought I should take him to Gandhiji, and Gandhiji will be able to sort out my problem. So she took him to the ashram, and she had to wait for a long time to go and meet Gandhiji. But finally she got an opportunity, and she went, and she could meet him. And then Gandhiji asked her, yes, what do you want me to do? So she said, Gandhiji, my son, he loves to eat a lot of sweets, and I know it is not good for him. Can you please tell him not to eat sweets or to decrease it? Gandhiji kept quiet for some time, and then he said, I don't have answer for your question. Can you come after 2 weeks? This mother was really disappointed. She was like, I waited for the whole day to meet him, and now he tells me that he can't give answer to this such a small question and to come after 2 weeks. But anyway, it was Gandhiji finally, so she listened to him. She went home and she came back after 2 weeks. And after 2 weeks, when she got to see him, then Gandhiji said, oh, Ma, you have come back again? Yes. And then he told the son who was there with him, don't eat too much sweets, it's not good for you, you have to control eating the sweets. This mother was really perplexed. This simple sentence, what he told this child, he could have told him 2 weeks back also. Why did it take 2 weeks for him to say this? Gandhiji saw the expression on her face. And then he said, Mom, I could have told him not to eat sweets 2 weeks back. But when I didn't know myself how not to eat sweets and how to control my tongue and how I should behave when the sweets are offered to me, if I don't know it myself, how am I going to tell him? So for the last 2 weeks, I have controlled my eating of sweets. I haven't eaten any sweets, and now I have the right to tell him that don't eat sweets. Okay. What is the message from this story? Can somebody tell me? What else? So yes, so when we tell somebody to do something, it is we who have to first think, is it possible for me myself to do it? And it's only then then we can say that we can expect from our colleagues what to do, right? And I think this particular area will be, this particular thought we should keep in mind. Simple thing about asepsis routines in the MNCU. We always keep harping about wash your hands. Okay, follow, don't touch this. Have you done scrub the hub? Have you done this? What asepsis you have followed? And then especially when the doctors are shouting at it, I'm sure it comes to everybody's mind, has he or she done it first before telling me? Isn't it? Yeah. And it is not just for asepsis routines. It's even when it comes to respecting our colleagues. We all expect respect from others, right? How much respect we give to others. If you respect somebody, the person will respect you back. And it is only with the mutual trust and respect that we can go and work as a team. Owning up the mistakes. None of us are perfect. And mistakes happen with everybody. It's when there is an extravasation of IV line that happens and somebody, one of your seniors comes and starts yelling, why didn't you see that first? I mean, that redness had happened. Didn't you check whether there was flow or not? How could you allow this to happen? But then doesn't it happen with me when I have, when I have put an IV line, or maybe, I'm busy with my work and I could have missed it. Sometimes mistakes happen in giving drugs. Sometimes mistakes happen in intubation. In anything, mistakes, see, we all are human beings. Mistakes ought to happen. The important part is we should own up the mistake and ensure that we don't repeat it. That is the way to go forward. Okay, so these things will happen only when each one of us, and I'm not talking about doctors also, each one of you, and once you become senior in your own field, remember there are people who are looking at us when we have become seniors. And if we don't own up our mistakes when they happen, then how do we expect our juniors to own up? Okay, so this Gandhiji story is something which we should keep in our mind when we are talking about working together, team building, and most of all, we all love to preach and advise, right? So that is the time we have to remember the story.
Recording in progress.
So, building leadership is not something that a leader emerges out of a group of people. A leader is somebody who takes everybody together with him or her. And that is when we are working as a team, because we know that little life which is there in the warmer or in the incubator or in the open care is completely dependent upon how each one of us are performing our responsibility to the perfect possible way. May it be nurses, physicians, even the people who are coming as cleaners, anybody, respiratory therapists, everybody has a role to play when it comes to working as a team. And we as leaders in our particular area, we have to ensure that we take everybody along with us when we are working as a team leader. And it includes the 6 essential leadership skills will include communication, delegation of work. When you enter in the MNCU and when you are the senior for that particular shift, then and you have some 2-3 babies who are there on the ventilator who need continuous monitoring, how are you going to delegate the task? Ensuring that you delegate it correctly to the person who is efficient and who can do that particular task well. If you delegate the task to a person who is not knowledgeable enough, who doesn't have confidence or something, mistakes are ought to happen. So important thing about leadership and of course communication between ourselves. What I want as a physician to tell the nurses, what the nurses between themselves they communicate, that is all important to make sure that the baby gets benefited finally. Adaptability. I mean, many a times in the NICU, there is always change of people. There will be juniors, there will be some nurses who will be leaving, the new ones will be joining, some doctors will be leaving, the new ones will be joining. Especially if you are working in medical colleges, there will be postgraduate students who will keep changing every month. Everybody comes with their own set of knowledge, experience, behavior, skills. And we need to adapt to all those things. We cannot say that this is the way I want you to work. Of course, we all have protocols to follow. We all have discipline to follow. But to some extent, adaptability to everybody's behavior, skill, knowledge is important to make the show going and to make it work. So training, of course, we all know that each one of us, and that's why we all are here to get ourselves trained. Connecting between ourselves, knowing the person, we all the team people who are there, challenging ourselves for new knowledge, and that's why again we all are here. We all ought to challenge ourselves for better skills, for newer knowledge, for different circumstances, and we all know in fact challenges is something which we face in our field every day, right? Because every baby comes with its own challenge. No baby is the same, right? Every baby has, even if you say 1.8 kilo babies, each one of the baby will have his or her own different set of ways of behaving. So challenge is something which we all come across every time. Coaching ourselves and coaching our team people. So all these become an important part of building leadership. That's what I said, training. Each one of you will come with some level of experience and knowledge when you come to workplace, when you change your workplaces. So what a good leader needs to know, whoever is a senior staff for that shift that day should know is who is skilled at what. And getting the work done from the person who is skilled there is what is important to get your job done. Because if you make sure that skilled person gets that particular job, you as a senior person, your headache is less. Okay, because again you are responsible to answer. And identify the skills between your colleagues, train them to position to that. Like for example, when some of you are maybe very good in explaining to the mother about the breastfeeding position. Some of you may be good in how to put the baby in KMC. Some of you would be very good in putting IV lines. So everybody would be, each one of you or us would have some good skill in some particular area which we need to identify, and especially as a senior person in the team we need to identify in order to make this job successful. Connecting between you, and see, one of the things which of course will come out in the panel discussion later on, what we are going to talk about is what is it that is going to help the nurses keep into the job, the neonatal nurses who are after training. And of course it has been said that praising somebody for the job, giving more money for what they have done, prizes, all that, these are external motivators. That is something which helps us keep going. But what are our internal motivators? What gives me the satisfaction after doing the job? That is my internal motivation, and that as a leader we need to ensure that we also satisfy them and give each one of them the chance for having mastery over a particular topic, autonomy. Sometimes there are certain, especially when there is a senior person in the team, the senior person would want everything to be reported, every small decision to be reported. Of course sometimes it is important, this reporting, but giving some autonomy to your juniors so that your junior colleague also feels empowered that yes, I can do this, and my senior person trusts me to do that. That sort of a feeling, that sort of internal motivation drives the purpose of working when you are working in a unit. And coaching, of course, is important. So it helps, that is, there is a whole lot of things which I can speak about coaching, but we will talk about some other time. And nurturing leadership. So we just not need to build, but how we nurture, how we help a plant to grow. That way, whoever is good in whichever position, if we help them to grow in that position, that is what is going to help in the long run. This is the story of the turtle and the rabbit. Yes. Let us relax and listen to the story.
The race. The turtle and the rabbit both agreed on a route and started off the race.
You all know the story, right? Yes. Okay, let's listen to the whole story.
Seeing he was far ahead of the turtle, he thought he'd sit under a tree for some time and relax before continuing the race. He sat under the tree and soon fell asleep. The turtle, plodding on, overtook him and soon finished the race. Emerging as the undisputed champ, the rabbit woke up and realized that he'd lost the race. The moral of the story is that slow and steady wins the race.
That is what we know.
This is the version of the story that we've all grown up with. But our version of the story continues. The rabbit was disappointed at losing the race, and he did some thinking. He realized that he'd lost the race only because he had been overconfident, careless, and lax. If he had not taken things for granted, there's no way the turtle could have beaten him. So, he challenged the turtle to another race. The turtle agreed. This time, the rabbit went all out and ran without stopping from start to finish. He won by several miles. The moral of the story? Fast and consistent will always beat the slow and steady. It's good to be slow and steady, but it's better to be fast and reliable. But the story doesn't end here. The turtle did some thinking this time and realized that there's no way he can beat the rabbit in a race the way it was currently formatted. He thought for a while and then challenged the rabbit to another race, but on a slightly different route. The rabbit agreed. The turtle and rabbit started off. In keeping with his self-made commitment to be consistently fast, the rabbit took off and ran at top speed until he came to a broad river. The finishing line was a couple of kilometers on the other side of the river. The rabbit sat there, wondering what to do. In the meantime, the turtle trundled along, got into the river, swam to the opposite bank, continued walking, and finished the race. The moral of the story? First, identify your core competency, and then change the playing field to suit your core competency. The story still hasn't ended. The turtle and rabbit by this time had become pretty good friends, and they did some thinking together. Both realized that the last race could have been run much better. So, the turtle and rabbit decided to do the last race again, but to run as a team this time. They started off, and this time the rabbit carried the turtle till the riverbank. There, the turtle took over and swam across with the rabbit on his back. On the opposite bank, the rabbit again carried the turtle, and they reached the finishing line together. Both the turtle and rabbit felt a greater sense of satisfaction than they felt earlier. The moral of the story? It's good to be individually brilliant and to have strong core competencies, but unless you're able to work in a team and harness each other's core competencies, you'll always perform below par because there will always be situations in which you'll do poorly and someone else does well. Teamwork is mainly about situational leadership, letting the person with the relevant core competency for a situation take leadership. And that is the end of the story.
Liked it? Yeah. So That's what I wanted to tell you when we talked about nurturing the relationship, leadership. But at the same time, we just need to remember that when we nurture, it is also the person whom you are going to nurture, the person whom you are going to mentor has to be also equally reliable, interested, committed, and teachable. Otherwise, all the work and efforts will go waste. So it is important that when you build your team, you have people who are interested to be a part of the team so that your efforts will not go waste at the end. And of course, it is important to have a shared vision. So what is it going to be our goal at the end of it? What is it that our NICU team we want to build up for? Or whatever, whichever way you are going to work, it is important that, you have a certain protocol. You follow those protocols because that is how everybody is going to work together and you are going to have, you are going to reach up to the goal. So if there is no vision, that is what will happen. If there is imposed vision, that is something which is told to you by somebody but you are not interested in, then this is what the middle figure which will happen. But if it's a shared vision, if it is something which you think and your team members also think, then you all will go together and that will be always for the benefit of the baby as a whole. So thank you, and this short talk, it is just to stimulate all of you to think. It is not really covering the whole topic, but that's what I thought I would deliver the message in this short talk. Thank you.
Surgeon, urologist and surgical gastroenterologist at Madilu Children's Hospital, Tumkur. He has done his post-graduation and MCH from CMC Velloor and PDF from the SGPGI Lucknow. Over to you, sir.
Right. Okay. This is forward. Forward, huh? Hi, good afternoon everyone. I hope all of you are bored by this time. It's already 4:15, probably post lunch, feeling sleepy, and a surgical topic for the neonatology. I think it will be boring. So I'll just start off directly with the surgical newborn. What you need to do when a surgical case is diagnosed. Once a surgical diagnosis is done, workup is towards a diagnosis. Okay, fine, I'll give a diagnosis. Okay, fine, this is the diagnosis. Then we need to work it up because we need to prove what is it. That is what we need to do. That actually it forms a part of the team. Actually, I'll come and tell, okay, fine, get an X-ray done. What is in the X-ray? What needs to be done? What needs to be informed to the surgeon? This is what I'm going to tell now. And associated anomalies. Once a diagnosis is done, what are all the associated anomalies which can be associated? If I'm missing something with investigations, I think the sisters can help me out sometimes. This is what I always expect in an NICU. And then preparation of the patient for surgery, it's most of the times it is by the sisters. The bloods, blood products, and all those things which want the relevant investigations, all these things needs to be seen by the NICU staff first and then informed, okay, fine, this is lacking, so we might need a different investigation to rule out. And then parent should be counseled by the neonatologist, a nursing staff, a psychiatrist, and all these people play a vital role in getting a good outcome and avoiding all the mishaps which happens in the hospital. These are all the things which needs to be done in a surgical newborn. Coming on to specific diseases, congenital diaphragmatic hernia, diagnosing diaphragmatic hernia. When you see this kind of a picture, when you see this kind of a picture, that is the bowel loops inside the thorax. I hope you all can see the bowel loops inside the thorax as well as the stomach. You can see, if you see this kind of a picture, it is almost always diaphragmatic hernia. It can be confused with eventration of the diaphragm, but at least if you tell this much, we can come to a conclusion of it needs some kind of a surgery.
That is all I want to know. And maintaining saturation. What is the saturation about? In this child, most important is saturation. And maintain a saturation of around 91 to 92. That is good enough. Even if the child is on ventilator. Don't go beyond it, trying to increase the PEEP or anything, because it might cause a pneumothorax. I don't want all those things. We just want a saturation to be maintained between 91 and 92. That is good enough for the child. And then Rayleigh tube aspiration needs to be frequently done, as the stomach might not work properly, and you need to decompress it so that the thorax moves a little better. And then ruling out other anomalies like doing an echo, ultrasound abdomen for ruling out renal anomalies, all these things needs to be done in the pre-op preparation of a diaphragmatic hernia child before shifting the child to theatre. And once the surgery is done, it's the normal protocol which consists of IV fluids, antibiotics, analgesics. I usually keep the child on ventilator, especially if it's a neonate. I will keep the child on ventilator for a day or two, and then we wean off the child. Otherwise, if it's more than 2 months, if it's a very easy case, we might extubate the child on table only. We might give you the child without intubation. And then Rayleigh tube aspiration is a must in all these children. And drain. Sometimes we might put a drain. Most of the times I don't keep a drain in a case of diaphragmatic hernia. Many of the times we may keep a drain in a case of CDH. Many surgeons they keep a drain. I don't usually keep a drain unless we do it thoracoscopically. Thoracoscopically, if we do, we'll keep an intercostal drainage. And as sister, this is all you need to know about diaphragmatic hernia. If you know this much and if you know this much of management, it should be good enough. And esophageal atresia with or without a fistula. It can be with or without a fistula, but that doesn't doesn't make any difference in the management by a nursing staff. It's only for the surgeon which makes a difference. Presence of a fistula or absence of a fistula. Usually the diagnosis. How do you diagnose on X-ray? The curl of the NG tube or NG tube will not be able to push beyond some 8 to 10 centimeters. That it curls around in the upper pouch. That is what you can see. And ruling out other abnormalities like heart defects and then renal anomalies and then vertebral defects. You need to take an X-ray and look for the vertebra, whether it is there or not. Sometimes you may find a hemivertebra, means one of the vertebra might, and look for the vertebra, whether it is there or not. Sometimes you may find a hemivertebra, means one of the vertebra might be X-ray. That you need to do, but that doesn't have any, and look for the vertebra, whether it is there or not. Sometimes you may find a hemivertebra, means one of the vertebra might be X-ray. That you need to do, but that doesn't have any of all these things before going ahead with surgery. And use of a Replogal tube. This Replogal tube is nothing but this is not commercially available in India. We make it ourselves by use of a 10 French suction tube. Inside that we pass a 5 French or a 6 French, depending on the hole made, 5 French or a 6 French infant feeding tube, and the inside tube, whatever 5 or 6 French infant feeding which you have put, you need to aspirate with that. This is done to avoid injury to the mucosa by direct suctioning, and suctioning pressure should be between 6 to 8 mm of mercury. That is what is the minimum amount of suction which you need to do. Otherwise the mucosa will get sucked and that injury will cause a shortening of the esophagus for us when we are doing an anastomosis. And post-op management, usually the child is kept on ventilator depending on the anastomosis. If the anastomosis is tension-free, we usually keep it for 1 or 2 days. If the anastomosis is totally lax, then we might extubate on table. Most of the times we keep the child on ventilator for 4 to 5 days. And this ventilation, this baby needs a ventilation which is very, very important, because you need frequent suctioning, because we would have operated on a trachea which shares a common wall with the esophagus. We would have dissected it. So it has a lot of secretions inside the trachea, which tube might get blocked. And we might not even realize by the time the child, we may lose the child by the time we realize it. So we need intense suctioning of these children with at least a little bit of saline, and then suction it out, then only the child you can ventilate very comfortably. Otherwise, we might lose the child post-op. And intravenous fluids and antibiotics and analgesics, these are all regular things. These will be looked after by neonatologists. Most importantly, the NG tube which we have placed, you should never touch it. No aspiration needs to be done, and you should never touch the NG tube. You can fix it more if you want it. It is always good if you don't touch the NG tube till the barium swallow is done post-op. or at least on 5th day we do a barium swallow. Till that time the NG tube should not be manipulated. And neck should be always in flexion. Because if you extend the neck, the anastomosis which you have done, it is almost close to the neck, so it causes a tension and it might cause a leak in the anastomosis. So we don't want the neck to be flexed, and NG we should not manipulate. These are all the two things which you need to be wary of when you have a post-op tracheoesophageal fistula child. And coming on to the next thing, atresia of the small bowel. These children might have abdominal distension or else have a scaphoid abdomen. If it is distal atresia, you can have, distal means in the small bowel, almost in the ileum, you can have a scaphoid abdomen or a flat abdomen. But if it is upper up, you will have an upper distension of the abdomen. So this is how it looks. If you find this kind of left side, you can see the picture, right? There are two bubbles, black bubbles. If you see that kind of a picture, it's always duodenal atresia. On the right hand side, you can see air fluid levels. You can see levels, right? 1, 2, 3, 4, 5 levels. So it could be probably jejunal or an ileal atresia. If you see this kind of a picture and the child does not pass meconium, then it could be probably atresia. Or there are some other diagnoses, but most of the times if they usually present with these X-ray findings, it will be usually some kind of an atresia. But sometimes what sister tells is, okay fine, child has passed stools, sir. This is what I get. What is the color of the stools? The color of the stools is more important, because sometimes the child passes mucus which is formed in the colon. You will find whitish stools. That also they think it as, this is stools, but that is not stools, it is just mucus. This you need to be, this kind of a stool along with this kind of a finding on an X-ray, which will always be atresia most of the times. And preoperatively management is IV fluids, that is regularly started, and Rayleigh tube aspiration, it should be done very frequently, otherwise the child will vomit and you will have aspirations and all other complications will start occurring. So you need to avoid that. Maintaining electrolytes, because you are aspirating the whole lot of bile, you need to replace it. Whatever the amount of fluid you are aspirating, that is bile, that you get a green color fluid. Probably you would have all seen green color fluid if you have aspirated. So that kind, how much ever amount it comes out, that much needs to be replaced with IV fluid along with potassium chloride. That will be told by the pediatric surgeon or by the neonatologist, how much amount is to be replaced. And arrange for FFP and blood products, as already told. And post-operatively, once the surgery is done, usually the child will have a drain and a transanastomotic feeding tube. We usually keep a feeding tube, I don't keep a drain. Transanastomotic feeding tube needs to be taken care of very carefully, because if that will be the lifeline where you can start early feeds. Sometimes the child might not recover so early as we think. Sometimes these kind of children, we have seen children staying in an ICU for 1.5 months. So we need to keep that lifeline, that is the transanastomotic tube, very, very carefully. We need to take care, like it's like a baby. For a baby, it's a baby, because it is dependent on that. Otherwise, you can't feed any time. And then antibiotics, analgesics, drain care, transanastomotic tube care, Rayleigh tube aspiration needs to be done. The more and more you aspirate secondarily, it will give the proximal bowel will be emptied and it starts functioning well, because the proximal bowel will be hugely dilated. It takes a lot of time to take back its peristalsis. To come back to its normal peristalsis means it has to push the foot down. It takes a longer time, because it is hugely dilated, the elasticity of the bowel is lost. So the more you aspirate secondarily means if you are dedicated, then you can make the child go early. And myelomeningocele, probably all of you would have seen, it's a swelling on the back of the neck. But these children need a nursing care. Specifically, these children needs to be maintained with, they should not go in for hypoglycemia. Main thing is, the child should be nursed in lateral or in a prone position. Never make them supine. Okay, otherwise it starts ulcerating, or it might even rupture. Ruptured myelomeningocele will have a deleterious effects on the health of the child. That's why. And X-ray spine to look for what is the defect, and regularly ultrasound abdomen to look for the kidneys, and echo for looking for the heart defects. Post-op management, you can start the feeds as early as possible. Within 24 hours we can start, but there will be a drain which needs to be taken care of which might give you a little bloody discharge sometimes, and wound should be infected very frequently, at least on the third day, and after that every day you need to inspect the wound because it will be under tension. It might give way sometimes. And CIC, many of the neonatologists might not be happy starting the CIC in a neonatal age group, but I usually prefer to start clean intermittent catheterization, that is taking out the urine as early as possible, because ultimately at some point of time these children will need CIC. Anorectal malformation, this is nothing but absent anus. An absent anus is nothing but an anorectal malformation. In these children, you need to look for many defects, like heart defects, even esophageal atresia can be there, even duodenal atresia, whatever atresias I've told. All these things can be present in these children. Okay, look for other anomalies like renal anomalies, because most of the children are associated with renal anomalies and they are associated with cardiac defects. You need to specifically see for VSD. Most of the times it will be VSD or ASD, and X-rays are a must in these children. Okay, at least after 24 hours you need an X-ray if the child does not pass stools, to look for what could be the reason. And most of the times what we see is, nobody would have seen the anus. Child is not passing stools, child is not passing stools. This is how we are called. Why? Because there is no anus only. Why? Where will it pass? That is how they call. So you need to inspect all the orifices when you are receiving the child in the NICU. It's a low URM where you can see the black pearls, blackish discoloration you can see just below the scrotum, right? Some small pearl kind of a thing. That means it is a low URM, because you can do a very easy surgery and get out of it. And in a female, usually it will be present, the anal opening will be present in the vagina. So you need to inspect whether it is in the vagina or in the normal position when it is a female baby. Okay. And then look for other anomalies, work up in detail. Rectal washes, we don't do surgery in these children so early. We take at least around 3 months so that the weight gain is proper, 5 to 6 kgs of weight, then we do a surgery. Okay. So till then, you need to identify the anal orifice, you need to start on rectal washes, you need to teach the parents how to do rectal washes. Rectal washes is nothing but putting an infant feeding tube around 7 or 8 number tube, I usually prefer, and pushing around 5 to 10 ml of saline or normal drinking water, you can push it, and when you are pushing it, you can draw the tube out so that the child passes the stools out. Because what happens is, this rectal washes will enlarge the anal opening, because at the time of surgery, if this is very small, it might lose a lot of intestine. We might lose it. So this, by the age of 5 to 6 months when we are operating, it will have a huge anus so that we don't lose bowel. Post-op management, we usually do in an intermediate arm. If it is a very low arm, it will be a single stage surgery. If it's an intermediate, means a little higher. If the rectum is ended little higher, then we usually do a stoma, means bringing out the bowel onto the abdominal wall. We usually bring you onto the abdominal wall, and the stoma care is more important. Probably a stoma care nurse will be there most of the times when you go abroad or else in a corporate hospital. But when you are working in a periphery or in other tier 2 cities, you don't get a stoma nurse. So you need to become the stoma nurse here. You need to take care of the stoma every time when the child passes stools. You need to clean the abdomen. You need to clean surrounding the abdomen, because initially for a week or 2, sometimes what happens is there will be a lot of redness, there will be excoriation of the skin. All these things can be prevented by using a Cialoderm ointment. That's the most cheapest ointment which is available. Or else if it's a little, if you can use, if it is really very severe, then you can use a Coloplast oil paste. You can use one of the two. If these two are not there, then the surgeon will be called. Okay, most of the times the follow-up is with the sister. Stoma care nurse will be following up these kind of children, rather than they will not come to our OPDs at all. Hirschsprung's disease, this is usually a little difficult diagnosis. Usually how you get is, on the first day child is normal. As day progresses, day 3 or 4, abdomen starts distending and you can see the bowel loops on the abdomen. That's the usual presentation of a Hirschsprung's disease. On the 3rd day or 4th day, you are having a distension of abdomen with palpable bowel loops. Means it looks like a valley. If you do it, you can see, you can feel the bowel on the abdominal wall. That is how it will be. So once you see that abdominal, if there are bowel lobes, then it needs a detailed evaluation. Usually it needs an X-ray abdomen. X-ray abdomen will show the absence of air in the pelvis. Okay, pelvic air gas shadow will never be there. That is really difficult as a nursing staff or someone to diagnose unless you are working only in an ICU where there are a huge amount of hair springs, and then rule out other anomalies. But the most important thing is to start on rectal washes early in these children so that the abdomen gets deflated. By the time we take it up for surgery, at least the distended bowel should come back to normal. That is what we want before we take it up for surgery, because otherwise the stomal complications are too much. And post-op management, once the stoma is done, start the feeds early, and stoma care as I advised. I did. Next day afternoon, they told the saturation is going down, 74. What to do, we didn't know actually. Then we started thinking, okay, fine, what could be happening? Then I thought, okay, fine, let me remove the tracheal tube. I removed because some conference they had told, okay, fine, there is a thing that, okay, fine, blockage of ET tube is the most common thing which can happen for the saturation to go down. So I just took out the ET tube. There was a blood clot which was blocking. Whatever the air we were giving, it was not going in at all. Once we cleared it and then kept the ET tube, tracheostomy tube back, the child was normal. So this is the most important thing which as a sister you need to know, because all the 24 hours we might not be there. First thing, you check the tube. Nothing will happen if you take out the tracheostomy tube, look for it and clean it. That's the best thing you can do. Once you have diagnosed that, if that is not there, then there should be something else, then a doctor can be called, because these things can be managed by all of you. It is nothing, just take out the tube, clean it and keep it back. Child will usually revive, because tracheostomy is one of the safest procedures where you can take out the child very well. And it is done as an emergency or elective procedure. As an elective procedure, we can take it to OT and it can be done. But in an emergency, in an NICU, we have to be equipped with tracheostomy set. You need to have 2 artery forceps, 1 needle holder, 1 knife, 15 number blade. All those things you need to keep it with a suture, and tracheostomy tubes should be available if you have plenty of patients if they are there. At least a 2.5, 3.5 tracheostomy tubes should be always there. Post-operative care, you need to look for the skin, how it is. And tracheostomy tube, whatever we have kept, even if you have kept 3, if it is not snugly fitting, if it is coming out frequently, then you can change the tube to some other size. You can reduce or you can increase, okay? And then most important thing in tracheostomy management is frequent suctioning of the tracheostomy tube, because it gets blocked because of the mucus. This you need to remember. At least hourly suctioning for 2 to 3 days is most important in a case of tracheostomy. And ventilatory support initially for around 2 to 3 days, we keep the child on ventilator, then wean off, then slowly we take it out, then we put it on a T-piece and then take off everything, okay? At the time of discharge, this is the most important work for all the NICU staffs. Teach the parents to suction at home. There are 2 types of suction, where one is mechanically suction. It is nothing but a cycle. You have seen cycle pumps, right? How they blow. It's the same kind of a thing where you can suction it. A suction tube is attached, and then with the leg you can do it. Or else an electrical suction is also available. If they are in metropolitan cities, they usually take up electrical suction. If they are from a village or from a tier 2 city where the electricity is fluctuating, then you can give a mechanical suction device. And dialysis, this is one thing which only probably St. John's, Narayana, and in Tumkur we are doing peritoneal dialysis in neonates. If very septic children with a creat of 7, 8, anuric child, we do a peritoneal dialysis. It is done as an emergency procedure, and all the
She's one. Hello. You're one.
MRP 6.5 साढ़े 4 साढ़े 5 हज़ार के